Okay, sure. Done.
Is my screen visible?
Yes, Darshan.
Okay. So, good afternoon, everyone. So, the first topic of the day is management of burns. This has been asked multiple times in the previous year question papers. So, coming to the definition of burns, it is defined as an injury which is caused by the coagulative destruction of the skin and its structures, either by thermal, chemical, electrical, or mechanical energy. A major burn is defined according to the percentage of the total body surface area which is involved. A burn, which is more than 25% involvement of the total body surface area, is considered to be a major burn in an adult who is aged more than 16 years. I'll go into the details in the next coming slides. Okay. So burns have been classified based on a lot of types. Okay, it might be classified based on depth, etiology, percentage of body surface area. Sometimes it's a combination of all of these. Okay, so usually what happens is by using these classifications, the management can be easier for us to gauge the severity of the burns and know what are the repercussions or consequences of that particular type of a burn. So coming to the commonest classification, that is the etiological classification of burn. Based on etiology, it can be classified either as a thermal burn, an electrical burn, a frictional type of a burn, a rub, or a chemical burn. Okay. In the thermal type of a burn, it can be either a contact injury like a hot surface or a hot plate, flame injuries, scald type of injuries owing to hot liquids. Coming to electrical burns, they can either be classified as high voltage burns or low voltage burns. Frictional burns are nothing but burns which are sustained because of crude force which is applied against the skin. Okay, and chemical burns either can be acid type or alkali type. Coming to the pathophysiology of burns, usually it's a complex traumatic event which is causing a tissue destruction, which can either be due to heat, radiation, chemicals, or electricity. So, when this event happens, it causes a trigger. That is, it triggers a localized systemic and local reaction, which causes dysregulated inflammatory and hypermetabolic state at that particular place. And then from the localized injury, it becomes a systemic problem. Okay. This systemic injury, which happens from a localized injury of a burn, is due to the massive release of cytokines, which causes a lot of oxidative stress and metabolic changes. Okay. Usually, a case of burn can be divided into two phases. That is the ebb phase and the flow phase. Okay. The ebb phase usually represents the burn shock phase. That is the earliest phase of a burn injury, and it is characterized by an inflammatory response causing increased systemic vascular resistance. Usually what happens is there will be increased loss of intravascular volume because of the burn injury. It causes edema in the surrounding non-burn tissue sites, which leads to impaired tissue perfusion, and it can be present up to or more than 48 hours. Because of the initial phase, the body goes into a shock like state, and a response as a responsive event, it releases catecholamines, ADH, and causes hemoconcentration. Okay, and because of the earliest phase in shock, it leads to decreased cardiac output in the earliest phase between 24 to 36 hours. In the flow phase, that is the second half of it, it causes a hypermetabolic state. Okay, it causes increase in oxygen consumption, carbon dioxide production, and protein wasting. This usually is the recovery phase, wherein there will be tissue regeneration processes which would have started in, and a catabolic state sets in. Coming to local injury. So, whenever we have a burn injury, it is usually having these three things in particular: the central zone of coagulation, surrounded by a zone of stasis, and the outermost layer is the zone of hyperemia. Okay, so you have the central area, that is the zone of coagulation, surrounded by the zone of stasis, which is again in turn surrounded by the zone of hyperemia. Okay, So the central area is the tissue which is having an irreversible damage. Okay, the stasis area is potentially salvageable if things are done at the earliest and the action is taken faster. The zone of hyperemia is the outermost zone wherein there is vasodilation and increased blood flow as a response to the burn injury. Okay. So what happens in shock? Burn shock, that is. Okay, it causes a distributive shock due to the capillary leak. That is because of the damage to the local vascularity and the release of a lot of cytokines. Because of the capillary leak, there is a lot of shift of fluid from the intravascular space to the interstitial space, causing tissue edema and hypoperfusion, which causes cellular injury. Okay, this in turn exacerbates the SIRS response, leading to impaired cardiac function. And ultimately, because of the earlier phase of shock, what would have happened is we would have also started resuscitating this patient, right, with fluids, etc. If it is not done in a judicious manner, that also can add to the worsening of shock in such patients. Okay, these are the stages of Burns shock. It starts from the capillary leak syndrome to fluid shift to SIRS and impaired cardiac function and end organ hypoperfusion and damage. Okay. Coming to immune dysregulation, I already spoke to you earlier telling that burns can cause immune dysregulation, right? It's a double edged sword. It is helpful. How is it helpful? It causes tissue repair, but at the same time, it also causes immense overflow of cytokines. So it does angiogenesis as well. And in the meanwhile, because there is an increased release of both pro inflammatory and anti inflammatory cytokines, it can cause immune dysregulation, which is happening only because there is an imbalance which is there in the earlier phase of burns. It initiates healing, like I've already said to you, but because of the imbalance, it can also cause SIRS. Okay, this SIRS is an eventuality because there is excessive release of cytokines and impaired antigen presentation, which causes the burns patient to be highly vulnerable to the infective etiology, if at all if anything is present in the surrounding. Okay. So usually what happens in a burns injury, there is increased release of cytokines. There will be disease associated molecular proteins and pathogen associated molecular proteins which will be released. Okay. And that causes a lot of cascading effects. It can lead to hypovolemic shock and vascular leak, impaired immune response, and metabolic changes. All of this together, okay, can cause immunosuppression, bacterial multiplication, hypermetabolism, leading to multi-organ failure and death. So, because the burn state is an imbalanced inflammatory condition, this causes SIRS, leading to multi-organ failure and death. Okay. So, this is what you need to remember. There is an imbalance or a dysregulated immune response in burns. Coming to the next topic, that is, what are the systemic effects of burns injury? So, because there is a SIRS phenomena which is set in because of the excessive release of cytokines, it affects all the organs from head to toe. Okay, so it can cause confusion because of hypovolemia. The cardiovascular effects can be, as worse as a cardiogenic shock sometimes. Okay, it can be present up to 48 hours. It can be either due to hypovolemia or direct effect on the cardia. Okay, the vascular effects, you all know, there will be capillary leak, there will be leak of fluid into the interstitium, and it causes tissue edema. Respiratory effects, it can be ranging from inhalational injuries right up from the nares to the alveoli. It can cause any sort of damage depending on the amount of inhalational burns that has happened. It can cause bronchoconstriction, and the worst case scenario would be the occurrence of ARDS. Coming to the splanchnic circulation and the peripheral circulation, or this is the circulatory system, because of hypovolemia and decreased cardiac output, the patient can develop acute kidney injury. Because of increased capillary leak and loss of fluid, there will be electrolyte imbalance that can cause ileus. Because of increased release of catecholamines, what can happen is the stress state sets in and it can cause stress related issues like a GI ulcer. Okay, so along with this, fluid resuscitation, which happens in the earlier phase, can also lead to systemic effects causing pulmonary edema, abdominal compartment syndrome, and tissue edema. Okay, so these are the ways that you have to explain about systemic effects of burns. Coming to the phases of healing. So we have understood what is the pathophysiology, what is the molecular way that the injury happens, and what are the systemic effects of burns. Now we are coming to phases of healing. So healing usually is under the four phases. It whatever happens like in the initial phase of burns, it has to be removed, and the body's mechanism to remove it is by autophagy, apoptosis, or oxidative stress, and thus induced killing. Okay, usually the healing process would be overlapping with the injury process, so certain parts of the body would be in a state of injury and certain parts of the body would be in a state of healing, so it is usually overlapping. So what happens in the first phase of healing? It causes immediate vasoconstriction. If the area of burns is large, it causes systemic vasoconstriction. But if it is a small wound, probably it causes localized vasoconstriction. Okay. By this, it causes platelet aggregation, clot formation, and if there is a vascular leak, it will prevent bleeding. Coming to the next phase of healing, which is the inflammatory phase, it involves recruitment of neutrophils and macrophages. That is the chemotaxis. Okay, it involves these cellular components to come to the site of injury to clear the debris and initiate the healing process. Okay, coming to the next phase in healing, that is the proliferative phase. The proliferative phase involves the movement of fibroblast and keratinocytes, usually to promote angiogenesis. Once angiogenesis is completed, then collagen deposition would begin. Once that is completed, the next step, that is the epithelialization, would occur. Okay. Coming to the last phase of healing, that is remodeling, it is usually strengthening of the earlier processes, that is the angiogenesis, collagen deposition, and epithelialization, which in turn restores the skin integrity. Okay, so these are the phases of healing. So this is a diagram which helps you understand the phases of healing. Initially, there will be hemostasis. Once hemostasis is achieved, the next thing would be the inflammatory state, wherein there will be movement of the cellular components. Okay, usually the macrophages and the neutrophils would come in that particular site. If there is any inflammatory or the infective etiology, that would be taken care of by the cellular components, that is your neutrophils. Okay, after that, proliferation phase usually involves angiogenesis, and remodeling usually helps in restoring the skin integrity back like how it was before. Okay, usually when the injury is too deep, the normal skin epithelium would not be formed, and something like an eschar would be formed. Okay, which will not be similar to the native tissue as it was earlier. Okay. So this phases of healing can start from the time of injury and can last up to 1 year. Okay, so it goes on for a long time. Coming to the management. So, how do we manage a patient with burns? Firstly, we need to assess the severity of burns. So, I earlier told you in classification, we spoke about etiology. Then we also spoke about the severity of burns as one of the types of classification. Correct? So, usually by Wallace's rule of 9 or London Browder chart or Palmer rule, we can assess the percentage area of the burns involved in the body. So the other way you can do is by the depth of injury, whether superficially it is present, that is the epidermal layer, or involvement of the dermis, or a full thickness burns. Okay. So to understand it better, so firstly we will talk about how the depth of wound is taken into picture as the classification tool. So if the depth of burns is taken into consideration, it depends on the involvement of the layers of the skin, starting from the epidermis, dermis, adipose tissue, muscle, and up to the bone. Okay. So if it is only the superficial thickness of the skin which is involved, it causes first degree burns, and it is characterized by pain. And only thing is, what is important to know is, apart from pain, there will be no blistering or there will be no scarring. Okay. So here the native tissue can, I mean, the skin will appear like how it was previously, or it will leave a very small mark. Okay. Coming to the second degree burns, it is usually characterized as involvement of both the epidermis and the dermis. In the second degree burn, it is characterized as superficial partial and deep partial. Okay. In superficial partial, usually the epidermis alone will be involved, but what you can see is sometimes it will be deeper up to touching the dermal layer, which can cause blisters and weeps. Okay, and with this, the increased capabilities of tissue damage, there can be an occurrence of infection. Okay, coming to deep partial thickness, it usually involves part of the dermis as well. Starting from the epidermis to the dermis, these usually form scars, but are less painful as compared to the first degree burns. Coming to full thickness burns, they are also called as third degree burns. They involve deeper parts of the dermis. Usually, the adipose tissue is not involved. Okay, they are insensitive to touch and pain. Okay, they do not have a lot of pain, such burns. Okay, but usually, what happens is they are going to involve a larger area of the skin, and the recovery phase of such type of burns would be delayed and slow, probably requiring even skin grafting. Okay, because it involves the dermis layer, and it is in a deeper dermis layer, the chances of infection in such burns will be higher. Okay, coming to the fourth degree of burns, that is the full thickness burns, along with the involvement up to the bone and the adipose tissue and the muscle. Okay, so this becomes quite difficult to treat. Sometimes the patient might require a longer time for healing, and in these cases as well, the patient will not have any sensation to pain as seen in the previous types of burns, that is your second degree and the third degree types of burn. So what we need to understand is, whenever the dermis gets involved and beyond the dermis, the chance of infection is higher, the rate of healing is slower, and the need for surgical treatment would be higher in such patients. That is starting from deep partial thickness, full thickness, and the fourth degree burns. I hope you guys are with me till here. Coming to the next understanding, so this actually is a tabular format of the same thing which I've already mentioned earlier. Only thing that you need to remember is, whenever you're asked to categorize based on the thickness, you can describe the answer in the following headings. Just write the layers of the skin on one side, and depending on the type of involvement, you can tell what is the type of capillary refill, sensation, and healing. Okay, so I've already mentioned earlier, mid-dermal, deep dermal, usually the pain will start reducing. Okay, only problem is, in these type of deep dermal and full thickness burn, surgery is the option. Epidermal, it is painful, but usually healing happens quite earlier. Blistering is one more thing that you need to see. Blistering is usually seen in mid-dermal, but deeper down again, it is not seen. That is in the deep dermal and the full thickness burns. So blistering is usually seen in the superficial dermal type of burns. Okay, so this is what we need to understand. And whenever there is blistering present, you also have to correlate to that to increased pain sensitivity. Okay, this is because the pain receptors are present in that particular area of the skin. Okay, coming to the other the types of categorization or calculation of the total body surface area of burns. London Browder chart are the most commonly used after Wallace's rule of 9. Wallace's rule of 9 is most popular and easy to use, that is why it is used. Okay, but if you see the accuracy of measurement, London Browder chart usually gives a better understanding. Okay, it's because as the age progresses, the area of involvement would start getting changed. Okay, so unlike Wallace's rule of 9, here it takes into picture the age of the patient, and the weightage for that particular area would be changing accordingly. Okay, so we all know, in the younger age group, area of involvement, if it is the face, the risk of injury would be higher, so the marking will be higher for that particular area. Okay, even though if it is a smaller part, it gets a higher weightage. Okay, But whereas as age progresses, the weightage comes down. Okay. Similarly, if you see coming to the body, it doesn't change much until that adulthood. Okay, the adult patient usually has a score of 36, whereas if you see from a younger age up to the age of 14, it is given a score of only 32. Okay, you should understand one thing: head takes in more priority in a patient who is of younger age, that is the pediatric population. As the age progresses, the involvement of the head, the scoring pattern comes down. Okay, so that is one of the reasons, because it involves the age and the site of burns for accurately measuring the involvement. It is told that it is a more accurate assessment tool for assessment of burn injury. So coming to the Wallace's rule of nine, we all know this from earlier. So it uses a score of nine for each part of the body which is involved. I'm not going into detail because this is something that we have been doing from a long time. Only thing is we need to remember it is different for adults as well as uh, younger population. Okay, here again, even Wallace's rule of nine gives the weightage for head, involvement of head as a higher score as compared to adults. In adults, you see it gives you a score of 4.5, whereas in pediatric population, it gives a score of 9 on each side, okay, front and back. So this is something that we need to understand. The other way to assess Burns injury is the Palmer rule. Or the what usually has to be thought about is, whenever we talk about Palmer rule of assessment of involvement of total body surface area, it is the patient's palm. So usually the palm of the patient, as seen here, should be considered as 1% if it the burn gets covered in the palm of the patient. Okay. So it is usually used as a quick method for estimating burns. Usually, minor burns is what you can use for Palmer surface. Major burns is always use Wallace's rule of nine or London Browder chart. Okay. So coming to classification of burns on the involvement of body surface area, I told you earlier it will be classified as a major burn or a minor burn. Burns is classified as minor if it encompasses less than 10% of the total body surface area with predominance of superficial type of burns. The usual type of care required here is symptomatic treatment. Major burns is usually defined where there is involvement of more than 10% of total body surface area in the elderly, 20% of total body surface area in adults, and 30% in children. It usually requires an intensive care in specialized burn centers. Okay. So, what are the components of major burns? Usually full thickness burns of more than 10% of the total body surface area, or partial thickness burns of more than 20% in the extremities of age at either pediatrics or elderly, or more than 25% of partial thickness burns in adults. Burns involving face, hands, feet, genitalia, perineum, and major joints. Inhalational injuries, chemical burns, electrical burns, and patients with burns with coexisting medical disease and burns associated with trauma will be classified as major burns. Predictors of outcome. So there are many scores which are present to help us understand the outcome of a burns injury. Box score is one of the scoring systems that have been used from a long time. So it combines the patient's age and burn size based on the total body surface area to predict mortality. For example, if it's a 50-year-old patient with a 40% burns, the box score is 90. Usually, it's a higher mortality risk. Okay, so the box score of less than 40 is considered to be safer. Modified box score involves, the presence or absence of an inhalational injury. It helps us provide a more accurate prediction tool for children, and also it doesn't, involve age group delineation as seen in the earlier score. One more important thing is, even if you know the calculation or not, if it is a major burns and usually if the patient has multiple comorbidities, we have to understand the mortality in such cases would be higher. Okay. Coming to the assessment of such patients, how do we go about? So, usually we do a primary survey, like in cases of trauma. So, firstly, we start with the airway and C spine. Check for the C-spine injuries, you can use your Nexus score, a Canadian C-spine score, one of these, and check for this, like in the case of trauma. Okay, look for signs of inhalational injury like singeing of hair, collection of soot, etc., or erythema in the oral cavity when you're intubating such patients, or presence of any sooty material. Okay, always secure the airway if you have a doubt of the losing the airway because of inhalational injuries. The threshold for such patients would be very low. Okay, so go ahead and intubate the patients if you feel that these patients can have one of the inhalational injury. Sometimes even carbon monoxide poisoning can also set in if the patient is present in a particular room for a prolonged period. Okay. Next thing we go about is from airway is the breathing and ventilation, like in any other ABCs. Always look for injuries which can cause any problem to ventilate the patient, like a large scar on the anterior part of the chest causing decreased excursion of the chest probably requires some escherotomy if at all it is present. Okay, look for signs of carbon monoxide poisoning. Okay, and usually for such patients you can start them on high flow oxygen therapy at the earliest. Okay, look for circulatory issues, check for your vital signs, get in your ABG, look at the other hemoglobins. If you have a good ABG machine, it will give you the other altered hemoglobinopathies if at all it is present. Hydrate these patients. Probably it would be judicious to start off with one of the formulas which I'll be mentioning later on, but always keep a check on the vital signs when you're resuscitating these patients. Okay. Look for any distraction injuries, if at all present, like in any other case of trauma. Okay. Always check the GCS score on arrival, documented. Look for other type of injuries, okay, along with burns injury, probably fracture, probably any other injuries associated with burns. Probably they might have had any other solid organ injury that has to be seen and addressed. Always locked roll the patient unless you have evidence that the spine is secure and safe. Okay. Most importantly, when you're treating a patient with burns injury, remove the pieces of jewelry, watch, or any other textiles like clothing which is sticking onto the patient. If the patient is a case of burns, that has to be taken care on appropriate measures, which I'll be discussing in the further slides. Okay. So the primary survey starts with, like any other case of trauma, airway, lower threshold for intubation, breathing and ventilation. Start with high flow oxygen. Look for signs of carbon monoxide poisoning. If your ventilation is difficult because of a large burn causing restriction of chest movement, probably consider for escherotomy if at all it is required. It can be any time, okay, initial phase or in the later phase. Circulation, start with IV fluid resuscitation at the earliest. Okay, look for hemoglobinopathies if at all it's present. Look for other injuries and remove any exposure events which are going to worsen the patient's condition in the long run. Okay, be it clothing, be it jewelry, anything. Always follow your trauma principles, even in the case of burns. Coming to inhalational injury, you should understand that the risk of inhalational injury is higher in a closed space. Okay. Presence of any facial burns or soot in the oral cavity gives an indication that the patient has suffered from a inhalational injury. Usually, you have to examine the posterior part of the pharynx, look for mucosal erythema, swelling, deposition of soot. Okay, if at all you have in patient presenting to you with stridor, hoarseness, or dyspnea, it is an indication of a severe case of inhalational injury, and for these patients, you should have a lower threshold for intubation. Okay. Coming to secondary survey, the secondary survey usually involves the laboratory analysis after you have secured the vitals of the patient. Okay, like in the case of trauma, always make sure that you have given the patient the tetanus prophylaxis. Whenever the patient is having a large burns, that is usually more than 15% of the total body surface area, you have to look in for dyselectrolytemia. You have to look into your complete blood count, coagulation profile, and arterial blood gas analysis. Routine evaluation, focused evaluation should continue. If at all the patient has any other trauma associated with burns, go ahead with your trauma workup, probably a polytrauma CT if required, based on the patient's presentation. Otherwise, appropriate radiological investigation should follow the workup of the patient after the primary survey has been completed. Okay. Coming to the systemic effects, I've already mentioned to you earlier what happens. In dysregulated immune response causes SIRS. SIRS causes multi-organ dysfunction, and multi-organ dysfunction, if not checked, can lead to death. So, what are the systemic effects of a large burn? It can cause metabolic derangements, immunological derangement, cardiovascular derangements, as well as respiratory derangement. Usually, the metabolic derangement is usually altered insulin response. It goes into a state of insulin resistant phase. So it goes on to conversion to a catabolic state, leading to increased muscle breakdown. Immunological response, I've told you there is an imbalance in the pro-inflammatory and the anti-inflammatory cytokines that leads to increase occurrence of sepsis. The first and foremost thing in burns we need to remember is these patients lose the first line of defense, that is the physical barrier for protection against any type of pathogen. If it is an inhalational burn or a burn involving the viscera, that is usually because of a chemical type of a burn. Even there, the gut integrity would be lost, and such patients can also have, impaired immunological state leading to infections. Coming to cardiovascular systemic effect, it causes depression of the cardiovascular system directly or indirectly. Directly, it causes it decreased cardiac output. Indirectly, it is because of hypovolemia, which leads to a decreased cardiac output state. Respiratory, it can start from as mild as a bronchoconstriction or a wheeze, and as severe to pulmonary edema and sometimes to a state of ARDS. Okay, so these are the systemic effects of a large burn. Coming to the phases of burn management. So the phases of burn management starts from the time of the burn injury up till hospital discharge, and sometimes even beyond that. That is, sometimes even they have to come back for multiple surgeries, so on and so forth. The first phase is usually the initial assessment and triage. So what we do here in the first phase is the first aid. Okay. So we'll look at what is the type of burn, what is the state of the patient's presentation, the primary survey and the secondary survey will be done, and then immediate care would be given to such patients. What usually happens is the resuscitation, burn wound coverage, and supportive care would be initiated at this particular state. Usually, rehabilitation would be followed on in the later stages. Okay. So, coming to first aid, what do? We stop the exposure. If at all the patient is seen at the site of injury and has come here, we have to see what type of whether the patient is still under the exposure of the etiologic agent. If it is an accident, probably they would have gotten into the ER and then to the ICU. Might not have much of an issue. But if it's a chemical type of a burn, if things have not been done either at the site of injury or in the ER, we need to make sure that these kind of etiologic agents are removed. Mostly fire injuries, etc., would be taken care of at the site of injury. Always remember, whenever the patient has injury caused by textiles due to a burn, remove those contaminants and this thing clothing. Okay, these can themselves exacerbate the burns in a long run. Okay, first and foremost, we should make sure that no home remedies have been used, or if at all they are used, make sure they are documented. Okay, when the patient comes to the ER or in the ICU, if depending on the type of burns, you have to use certain agents. The most important thing is to prevent hypothermia in these patients. Extremities of age, that is the elderly and the pediatric population, are at a higher risk for occurrence of hypothermia. So blankets should be provided to them when they have come into the ER or the ICU to prevent heat loss. Okay. Thermal burns, whenever they are present, they should be taken care by extinguishing them. Okay, chemical burns, usually you should use copious water. Always make sure when you're treating a case or exposure injuries that you don't get hurt yourself. So you should wear protective equipment as and when possible. Okay. And in case of electrical burns, always make sure that whoever has been doing that, if at all this time kind of injuries can happen even in the hospitals. So if any such injuries happen here, how do you treat that particular patient, or if you are at the site of injury, how would you take care also matters. Okay. So if at all there is an electrical burns that is happening probably in your ICU or in any of your surrounding areas, stop the current before touching the patient and then switch off the insulator. Okay. So these are the things that is overall about first aid of a patient with burns injury. Coming to phase two, that is the most important phase of a burns management, that is the fluid resuscitation. Usually, the goal of fluid resuscitation in burns would be promptly to restore the vascular volume, preserve the tissue perfusion, which minimizes end organ damage, and judicious fluid resuscitation should happen to minimize tissue edema. The Parkland formula is the one which has been used worldwide and has a lot of papers or evidence coming out based on this formula itself from a long time. It is also endorsed by the American Burns Association, but multiple trials in the longer run have said us to use fluid lesser than 4 ml per kg for total body surface area. So, what does Parkland formula say? It says that the initial fluid resuscitation is 3 to 4 ml per total body surface area percentage of burn into the weight of the patient in kilograms. You should give the first half in the 8 hours and the next half in the 16 hours period. Okay, I will repeat it again. Parkland's formula uses 3 to 4 ml of crystalloid solution of total body surface area percentage into the weight of the patient. Okay, so this crystalloid solution which they have used is the Hartmann solution. The first half of the calculation is given in the 8 hours and the second half in the next 16 hours. Okay, so this is about Parkland formula. Okay, so what happened is the ABA felt that the 4 ml per kg body weight can be an overestimate if we are using it as a blanket rule for all the patients. Okay, so that is one of the things they thought about. They always suggest that we start with use of balanced crystalloids as much as possible. Whenever there have been use of normal saline, there have been increased incidence of hyperchloremic metabolic acidosis. In a case of burns, similar like any other injury, it can predispose the patient to develop coagulopathy. Okay, so that would not be necessary. In cases where the requirement of crystalloid solutions are larger, there have been reports of use of albumin solutions to reduce the volume of fluid which is being used for resuscitation. Usually, it is to prevent tissue edema and in the long run to prevent even abdominal compartment syndrome. Why does this happen? Because there can be inadvertent leak of the fluid from because of capillary permeability, causing interstitial edema later on, leading to probably abdominal compartment syndrome. And this process is called as fluid creep, which I'll be discussing in the later slides. Okay. So what they said is whenever you're giving a fluid therapy or use one of the formulas like Parkland formula for fluid resuscitation, you have to check for the clinical response. So what is the clinical response? You have to check whether the patient's sensorium is improving. Has the patient become more alert? Has the vitals stabilized? That is, the systolic blood pressure is more than 100 millimeters of mercury. The tachycardia is settling down. That is a pulse rate of less than 120 beats per minute. Tachypnea is coming down with the respiratory rate less than 24, or urine output criteria of roughly around zero point 0.5 to 1 ml per kg per hour. What they say is urine output gives you a better understanding of fluid resuscitation in such patients. Okay, usually the target would be around 0.5 ml per kg per hour. Okay, so the other formulas which have been used are Evans formula, Slater's formula, Brook and modified Brook. Okay, I'll not be going into details of each thing. What you need to remember is the Parkland formula. Okay, remember it is 3 to 4 ml per total body surface area of burn involved into weight. First half 8 hours, second half 16 hours. I think so. If you remember this formula, it's more than enough. You can remember the names of others. Okay. The most important thing is you need to remember Brooks' formula involves the resuscitation with a colloid. Slater's formula uses fresh frozen plasma. Okay, and Evans formula uses 5% dextrose. Okay, so this is something that you, if you remember, that would be sufficient. Okay, but Parkland formula, there is no go. You have to remember the formula. Coming to goal directed therapy. So, earlier I spoke to you about a concept of fluid creep. What usually happens is if there is injudicious fluid resuscitation, it can cause interstitial edema and subsequent organ damage because of fluid retention or third spacing of fluid in such patients. Okay. So, what they said is if resuscitation is adequate, the urine output should be roughly around 0.5 ml per kg per hour. That is the target. If that is not reached, look at the alternate causes of acute kidney injury. It can be because of rhabdomyolysis or acute tubular necrosis. You should also rule out other causes of shock. So, shock should not always be attributed to fluid loss. Okay, looking for vasoplegia, looking for cardiac depression. Probably the patient might have developed a Takotsubo cardiomyopathy. Okay, so these things have to be looked into. Always assess for the development of fluid creep. Okay, additional monitoring like cardiac output monitoring would be necessary. Having said this, there is no evidence or mortality benefit for such type of goal-directed fluid therapy in burns. So, what is fluid creep? Fluid creep happens in burns resuscitation because of unintended excessive administration of IV fluids. Okay, it usually happens when more fluids are given and there is no hemodynamic response that is being monitored. Okay, usually it's quite difficult to do this. There is a huge problem in monitoring burns patients. So, like in any case which has challenges in critical care, monitoring of a burns patient becomes a challenge. Okay, so that is one thing that you guys have to mention in your answer sheets if you write it down. Probably the ECG leads application would be a problem. Securing an IV access would be a problem. Securing the airway would be a problem. Okay, and nutrition in burns would also be a huge risk factor or an hindrance. So these are the challenges of burns management that you might have to mention about. Okay, I've not mentioned these in detail, but I'm repeating here so that you know it. So you start from head to toe whenever the challenges of burns management are present. It's from head to toe. If you start, probably exposure injuries, that would be a first and foremost problem, leading to improper management of monitoring, that is your placement of ECG leads, etc. Vascular access would be a challenge again. Probably you might have to secure an central venous access. Sometimes even you have to do a venous cut down if you cannot find an access. Coming to airway management, it is difficult airway scenario that you need to mention about. Okay, because of one, probably injury to the face itself. Secondly, inhalational injuries. The next part would be fluid resuscitation and associated problems like abdominal compartment syndrome. The last thing would be about nutrition and rehabilitation of such patients. So these are the challenges of burns management. Okay, I just remember this, so this is what I wanted to tell you in detail. Okay, so the complications of fluid creep would start as early as just simple tissue edema, but can worsen, leading to severe ARDS because of pulmonary edema or damage caused by inhalational injuries, or compounded by both of them, abdominal compartment syndrome and electrolyte imbalances. So, to prevent this, the British Journal of Anesthesia and the Burns Society of Scotland came up with a algorithm to manage patients with burns. So initially, what they said is instead of using 3 to 4 ml per kg, start between 2 to 4 ml of Parkland's formula, that is roughly around 2 ml per kg, and start resuscitating the patient. Once you are able to reach 0.5 ml per kg per body weight, that should, if urine output every hour, you can continue with the same fluid management which has been given. If you feel that it is less than 0.5 ml per kg per hour, then you need to give a fluid challenge of roughly around 250 ml. Okay, and then increase the baseline fluid rate by 10%. Okay, but if you feel that the urine output has increased to 1 to 2 ml with the 2 ml per kg, then you need to reduce the fluid by 10% so that excessive fluid delivery to the vasculature would be reduced. If the if the urine output is more than 2 ml per kg per hour, then you need to reduce the fluid rate by around 25%. Okay. So starting again, you take the patient's weight. Okay. Then use Parkland's formula. In the formula, use it as a 2 ml per kg body weight per total body surface area of burns involved. Okay. And if you calculate that and you start off with the first 8-hour management, you have to check the urine output every hour. If the urine output is reaching around zero point 0.5 to 1 ml per kg per hour, continue with the same calculation which you have started with. If it is less than zero point 0.5 ml per kg per hour, first give a fluid challenge of 250 ml per hour up to 3 hours, and then consider adding NORAD or increase the fluid rate by 10%. Okay. If the urine output is more than 0.5 ml per hour, that is between 1 to 2 ml per kg, reduce it by 10%. If it is more than 2 ml per kg per hour, reduce it by 20%. Okay. They have also said that you can use something called as a colloid rescue. That is usually at the end of 12th hour, if the volume required is more than 6 ml per kg body weight per total body surface area of burn involved, you can use one third of this fluid volume as a colloid, that is 4.5% albumin solution. Okay, so this is something that you need to consider. The colloid here used here would be 4.5% albumin or 5% albumin. One of these you can use. Okay, I hope it is clear. It's not a standardized guideline. This is one of the things that they have mentioned to prevent fluid creep and the repercussions of fluid creep, which can be either abdominal compartment syndrome, ARDS, or other issues related to fluid overload. Coming to the role of albumin, so we told in the previous algorithm and in the formulas mentioned earlier, that is your Brooks formula, etc., where they use colloid as a resuscitative fluid, and the most common colloid that they have used is albumin. And mind you, whenever I speak of albumin, it is 4.5% albumin, which have been tried in many trials. Okay, so usually the advantage is plasma volume expansion. The thing which has been mentioned in most of the trials is the 20% albumin or 5% albumin, not the 4.5% albumin. So remember, that is one thing. Capillary leakage were comparable when they were seen in patients with burns or in healthier volunteers. So just because there will be capillary leak, whether use of albumin can prevent this is something which is still debatable. Definitely, it will maintain colloid outcotic pressure. Definitely, it will help in maintenance of intravascular volume, thereby preventing occurrence of acute kidney injury. But these things have still to be proven in the larger population. Okay. Most importantly, we need to remember plasma expansion whenever albumin is given is for a specified period of time, roughly around 6 hours. Intravascular volume in burns patients can roughly range, up to 10 hours. But beyond that, the effect definitely will come down at that particular time. Whether whatever we have done will matter or not will be questionable. Always there's an issue of the cost benefit analysis, so that cost factor also comes into play when we are considering the use of albumin as a fluid displacement therapy in burns. So we have spoken about a lot of things like volume expansion, prevention of end organ damage, etc. So what is the evidence saying for the use of albumin? There was a trial which was done way back in 2004. That is the NEJM article called the albumin study. It did show some, improvement in patient with burns. The population of patients they recruited were burns patients having a burn with a total body surface area of being more than 15%. The specifics of the depth of burns and tissue damage was mild to moderate, like roughly around superficial partial thickness burns. Okay, so in this they said that the use of albumin definitely came down on the need for crystalloids for resuscitation, especially in the second half of the resuscitation. So first half of the resuscitation, definitely the fluid of choice is crystalloids. In the second half, better to use albumin to prevent excessive use of crystalloids and fluid therapy. Okay, but later on, multiple trials have been seen. The Cochrane review in 2001 given that there was insufficient evidence to use albumin as a routine fluid therapy in management of burns. So one thing they saw was mortality outcomes. So that definitely cannot be used as a yardstick for every outcome. So still, uh, guidelines for the use of albumin is not present. American Burn Association does not recommend the universal use of albumin in non-patients with burns injury. One thing most of the burn societies agree on is if there is large fluid volume required for resuscitation, probably at that particular time, based on your hemodynamic assessment, you can use albumin as a substitute for crystalloids because the volume of resuscitation which is required would be less. Okay. Coming to the phase three of burn management, that is the wound management, it starts with the use of topical and antimicrobials. Overall, there have been no widespread evidence to say that this will prevent the occurrence of systemic sepsis. Okay. Earlier, skin grafting and excision might be necessary. Depending on the depth of wound involved, the type of uh, wound management comes into picture. That is, your either your split skin grafts or partial grafts, or so on and so forth, which the plastic surgeon takes a call on. Temporary coverages using allografts, etc., have been tried. Skin substitutes like your tilapia skin or synthetic biosynthetic materials. A lot of uh, tools have been coming onto the market quite recently. These have been used in the wound management of lately. Okay. Coming to sepsis and burns, because we are talking about wound management, like in any other case of sepsis, the American Burn Association gives you a criteria for burn sepsis. Okay, so whenever the patient has at least three of the following, we should consider that the patient is going into sepsis. A temperature of usually more than 39 degrees Celsius, okay, or a heart rate of more than 110 beats per minute. I'm sorry, I forgot to write that. Progressive tachypnea, thrombocytopenia, hypoglycemia, and inability to continue enteral feeding for more than 24 hours. If any of the three are present in these criteria, the suspicion of sepsis should be made. Along with this, if you have any culture proven sepsis, so you definitely have a pathogen identified, and then based on that, you can initiate your antimicrobial therapy. There is a Mann-Salinas predictor tool also present, wherein he says if tachycardia is present of more than 130 MAP, usually less than 150 mm of HGM, sorry, and a base deficit of more than 150. Uh, Usually these patients end up having severe sepsis. Okay, I think so. I've misplaced a lot of parameters here. Okay, so I'll be updating this in the slides and then putting it up. Coming to supportive care, that is your fourth phase. Usually, it focuses on wound healing and prevention of hospital acquired complications. It looks into hemodynamic support, nutritional optimization, pain management, and prevention of complications. Okay, so this is what is involved in the fourth phase, and the last phase is rehabilitation. So this is one thing that we need to mention when we are talking about wounds management in general. You need not go on writing each thing in particular. Okay, you just have to mention the headings, that would be sufficient. Rehabilitation starts with wound management, probably with your skin grafting, and in extreme cases if there is a loss of limb, etc., probably use of prosthesis or additional adjuncts have to be mentioned. Most importantly, the use of counseling tools, because these patients are also prone to depression, they have to also be mentioned as a rehabilitative tool. What usually happens is we look at all the physical things and we forget about the psychosocial impact which burns has, so that has to be mentioned along with your other management things in rehabilitation. So this is in general about the management of burns. Okay, thank you. I've already shared the article from which I've done the class and your article section, so you can read it. Okay, it's from the Nature Primer. It's a wonderful topic. So most of the things I've taken from there itself. So if you have any doubts regarding this particular criteria, please look into this. I think so I've made an error writing it down. Okay, so that is your Mansellus concept. Okay, so thank you.
Thank you, Darshan.
Thank you, ma'am.
Able to see my screen, Darshan?
Yes, ma'am.
Okay. So good evening, all. So our next topic would be about renal transplant. So it's a very important topic. So we'll be discussing about two important transplants. One is renal and one is the liver transplant. So before going to this, I want to just share that there are no fixed guidelines, okay, that renal transplant patient has to be managed like this, either the recipient or the donor. Okay, it actually varies in from different hospitals. So, but the basic thing which is very important, I'll be dealing with. Okay. So I'll be dealing with the introduction. What are the indications of the renal transplantation? Contraindications. How to prepare the donor as well as the recipient. Some important points on the surgery which we should know as an intensivist. And major ones are the early complications for which the patient will be admitted to the ICU. And second is the immunosuppression. And the last single slide on the long-term management of this kidney transplant patients. So kidney transplantation is the optimal treatment for those patients with end-stage renal disease, offering a survival benefit compared to dialysis. So these kidney transplant recipients, they are medically complex because they have a lot of underlying comorbidities, okay, other than the end-stage renal disease. So, and 10% of these recipients, they usually require the ICU admission. So coming to the primary reasons for ICU admission for these patients, one is any cardiovascular complications, second, respiratory compromise, third, sepsis, and the last one is post-transplant vascular and urinary complications. So these recipients, they are admitted to ICU, they have a higher rates of AKI. Okay, if you see the creatinine might rise in a day, in a second or third day. So what could be the causes of AKI in post transplant patients? So one would be because of ischemia reperfusion injury, surgical complications, any acute rejections, adverse effects from the immunosuppression, graft pyelonephritis, and the last and not the least is the sepsis. So what are the indications? So the first, the most common indication is the chronic kidney disease with stage 4, where the GFR is less than 30 ml per minute. So common causes for this chronic kidney disease are diabetes and hypertension, the most common cause, or it could be pre-renal, renal, or post-renal causes. The pre-renal causes are chronic or acute ischemia. The intrinsic renal causes could be glomerulonephritis or focal segmental glomerulosclerosis. And the post-renal causes could be, the most common is the obstructive uropathy or reflex nephropathy. Now, there have been a lot of studies which showed that there is a clear survival benefit for kidney transplant recipients over those who remain on dialysis. But one thing you should remember, that as the length of time on dialysis is increased, that is one of the independent risk factor for poorer outcomes post-transplant. So better if you have diagnosed the patient on CKD, if there is a possibility, you have to give an option for kidney transplant. Now coming to the contraindications. Okay, so these contraindications are divided into absolute and relative. So absolute contraindications include, very important thing, if the patient or the recipient has an inability to tolerate surgery due to severe cardiac or pulmonary disease. Okay, the second one would be any active malignancy or active infection. Third, if there is, the persons have the active drug abuse, okay, whether it is smoking, whether it is alcohol or any other drug abuse. And if the patient has an uncontrolled psychiatric disease, then these are the absolute contraindications to the kidney transplantation. Coming to the relative contraindications. These relative contraindications, they differ depending on the institution and the geographic region. So the most common being any morbid obesity patient with a BMI of greater than 40. If the patient has history of non-compliance with dialysis schedule or medication regime, because post-transplant these patients might not take their immunosuppressive medications also properly. And the third one is fragility, or patients having any psychiatric problems, or if there is a limited life expectancy, which is defined as less than that anticipated waiting period for a kidney. Okay. So the NOTO guidelines have given these absolute and relative contraindications. NOTO stands for National Organ and Tissue Transplant Organization. Okay. So they have given the absolute contraindications being active cancer, or if the patient has a HIV positivity or AIDS patient. If there is an active infection, it could be either UTI, tuberculosis, and the patient has irreversible underlying causes like heart failure, lung failure, or liver failure. And if the patient has any systemic disease like lupus, sickle cell disease, or vaginous granulomatosis, those patients have an absolute contraindications to kidney transplantation. Coming to the relative contraindications, so HBV and HCV infections are considered as a relative contraindication, but HIV is an absolute contraindication. And morbid obesity, atherosclerosis, underlying cardiac disease, uncontrolled hypertension, smoking, and unresolved psychosocial issues are the relative contraindications. Now coming to the preparation. So first we will see about the recipient and then we'll go to the donor. So which patients do you select for kidney transplantation? So most of these end-stage renal disease patients, they have multiple comorbidities, right? And the complications resulting from their kidney disease. So each patient has to be carefully screened for their ability to tolerate surgery and the subsequent immunosuppression. So now suppose if the patient has an underlying cardiovascular disease, okay, how to actually prepare this patient for surgery? Okay, so most of these ESRD patients, they require careful cardiovascular evaluation with a non-invasive testing for those who are at high risk or those who have symptoms. Okay, so we all know that leading cause of death after kidney transplantation is the cardiovascular disease. So all patients who have an underlying cardiac disease, they should undergo some non-invasive testing. Most common, it would be a dobutamine stress echocardiogram, which is usually performed preoperatively. If this non-invasive testing has come positive, okay, then these patients have to undergo cardiac revascularization before the transplant surgery. Otherwise, if you do a transplant surgery, his life expectancy anyways comes down because of the cardiovascular disease. So any underlying or risk factors for cardiac disease has to undergo a non-invasive cardiac test. If he comes positive for the non-invasive cardiac test, then the patient has to undergo CAG and, if possible, revascularization before kidney transplantation. This is if the patient has a underlying cardiovascular disease. Suppose if the patient has a cerebrovascular disease. Suppose any patient with a history of CVA, including the transient ischemic attack, they should be evaluated for carotid artery disease, because the thrombosis in the major arteries even cause a thrombosis in the renal arteries. So you need to evaluate even the cerebrovascular state of this patient. Additionally, if the patient has any polycystic kidney disease and accompanying symptoms, it warrants an MRI to rule for any aneurysms in the brain. Okay. And one more thing is we have to see for the femoral and the dorsalis pedis pulses. Okay. Especially in the PVD, you feel that you will not be able to palpate these pulses. In such cases, you need to do an ultrasound or a CT and refer them to a vascular surgery, because the important thing for us is the external iliac artery flow should be proper, because we will be actually anastomizing all these arteries. I mean, the donor kidney will be anastomosed to the recipient's iliac artery. So we should have a proper flow. There should not be any thrombosis. So we need to do a ultrasound or a CT before doing a kidney transplantation, only in case of peripheral vascular disease, if the patient has an underlying peripheral vascular disease. Okay, and if there is anything, then we have to, the patient has to undergo revascularization before the kidney transplantation. Now coming to the gastrointestinal disease. If any of these recipients have a family history or a personal history of colon cancer, or if the patient's age is above 50, they should have a screening colonoscopy done, okay, to rule out any active malignancy. And anyone with active viral hepatitis or a chronic liver disease should have a consultation with a hepatologist for a possible consideration of combined liver-kidney transplantation. Now, coming to the hematological disorders, as I told, if the patient has any thrombosis history, it has to be evaluated properly. You have to send all the hypercoagulable, workup to rule out if the patient has any underlying APLA or any other uh, autoimmune disorders. So, for those who have a bleeding diastasis, a full coagulation panel should be done. And as we all know, infections has to be ruled out. So you have to send your procal, you have to send all the cultures also. And active infection is an absolute contraindication to a kidney transplant. Now, suppose if the patient has malignancy, as we told, active malignancy is a contraindication. Okay. Otherwise, if the patient has a history of malignancy and is been cured and he has a cancer-free period of around 2 to 5 years, then the patient can be a transplant candidate. Okay. So coming to the pulmonary diseases. So which patient should undergo pulmonary function tests preoperatively? Okay. So first, if the patient is on dialysis for an extended period of time, those patients have to undergo pulmonary function tests. Second, if the patient has any heart dysfunctions or a known case of COPD, or if the patient has a history of extensive tobacco use, obstructive sleep apnea, or a history of pulmonary embolism, these are the patients who have to undergo pulmonary function tests and should undergo an echocardiogram to rule out pulmonary hypertension. Suppose if you have diagnosed, yes, this patient has a severe pulmonary hypertension, then you have to treat the patient preoperatively, stabilize, and then plan for transplantation. Okay, and the last one is about the fragility. So what is this fragility? It is nothing but a short physical performance battery from which an objective score is calculated. So basically it determines the candidate's fitness for transplant. And it is usually done for those patients who are more than 60 years. Okay, so the most commonly used fragility test is the Fried fragility test. Okay, which uses some components. Okay, so you have to see whether the patient has any unintentional weight loss, if the patient has self-reported exhaustion, we have to assess for the grip strength, whether it is weak or okay. And if the patient has a slow walking speed and a low physical activity, then these patients are not fit for kidney transplantation. So important is fragility of the patient should also be considered. Okay, so this is how you uh, prepare the recipient for the kidney transplant and how do you stabilize these patients before kidney transplantation. I think I'm clear till now. So next we have to do donor selection or allocation. So how do you select these donors for kidney transplant? So there are two types of kidney donors. One is living or the other is the deceased. So first we will deal about the deceased donors. So this deceased donors can be obtained after donation after brain death or they could be donation after the cardiac death. So DBD and DCD. So what is DBD? Donation after brain death. These are the donors who have satisfied the formal criteria for brain death testing. Okay, there are a lot of criteria, right? If they have satisfied this, then these patients are known as donation after brain death. And what is donation after cardiac death? So here the procurement of the organs cannot begin until the heart has stopped beating. Okay, so after the heart has stopped beating, then when you take these donors, this is known as donation after cardiac death. Now coming to the living donors. Okay, this is very important, living donors. So living kidney donation, it offers the best graft and also it has a best recipient survival compared to the deceased donors. Okay, but what is the eligibility criteria for these living donors? Okay, they should be in the age group of 18 to 70 years. Their BMI should be less than 35. There should be no active malignancy or no active infection and their estimated GFR should be more than 80. Okay, so these are the eligible criteria for living donors. Now, what are the contraindications for the living donors? So, BMI greater than 40 is a contraindication. If the patient has diabetes or active malignancy, HIV positivity, or if his GFR is less than 70, then he can't give his kidney. Albuminuria if the patient has, and hypertension requiring more than one medication. Okay, so mild hypertension is okay, but if the patient is having more than one medication to control his BP, then they are not fit for uh, kidney transplantation. Or if the patient has a pelvic or horseshoe kidneys, and if there is an underlying psychiatric disorders. So these are the contraindications for the living kidney donation. Now coming to the few point of surgery, I'm not going to tell in detail how the surgery is done or what. So just some important points which we should know. So basically we all know that two surgeries will be done. One is for the donor and one is for the recipient. So approaches for donor could be either minimally invasive or open surgery. Basically minimally invasive surgery is done for deceased donors, and for living donors usually open surgery is done. So this minimally invasive surgery could include a laparoscopic or a robotic surgery. Okay. And when it comes to the implantation, means if you want recipient surgery, recipient transplantation is always open. Okay. So what do you do there? Where the kidney is actually placed heterotropically in the pelvis, and you anatomize the vessels to the external iliac vessels, and you have to anastomose the ureter to the bladder. Okay, this is how the surgery is performed. And the most important for us to know about is the organ preservation post removal of the organ from the donor. So you have to know about two important variables here. One is the cold ischemia time, the other is the warm ischemia time. So once the organs are procured, they must be preserved before the eventual implantation. So during this process, the procuration to the eventual implantation, okay, there is a lot of ischemia which happens, okay, and this decides about the survival of the renal allograft in the recipients. So what is cold ischemia time? So it begins as soon as the normal perfusion stops, okay, either after the cardiac arrest or uh, basically in DCD, it is post cardiac arrest, and it ends when the kidney is reperfused in its recipient. That is the cold ischemia time. So during this time, the kidneys should be placed on the ice for as much of this time to diminish the metabolic demands and minimize the injury. So the normal cold ischemia time for kidney transplantation is 24 hours. The maximum is 24 hours. Now coming to the warm ischemia time. This is considered as more harmful to the organ. So we should not increase the warm ischemia time. Okay, so it is described as the Seven time when the organ is removed from the cold storage until it is ultimately reperfused following the vascular anastomosis. Okay, so you remove the organ from the cold storage to the reperfusion into the recipient. That is known as warm ischemia time. And for kidney transplantation, the warm ischemia time is usually 20 to 30 minutes, and it should not extend beyond 60 minutes. Okay. Now coming to the complications. As I told, most important as an intensivist is that we have to manage the immediate post-operative complications. The later thing will be seen by the nephrologist. So the immediate, what could be the complications? One is the hypertensive urgency or emergency. Second, urological complications, like if there is a urine leak or urinary obstruction. Third, if vascular complications like arterial and venous thrombosis or any iatrogenic vascular compromise. So we will go with each one of it and how to diagnose and how to manage. So first one is the hypertensive urgency or emergency. So I think most of you people have seen that when you receive the patient from the renal transplant, within around 5 to 6 hours, the nurse comes to us and tells that, ma'am, the BP is too high. Okay, and if you see it is more than 180 or 200. So in such cases, that is a hypertensive emergency, how do you manage these patients? Okay, so first we'll know what is the cause of this hypertension in the post-operative period. So it could be because of the peritransplant hypovolemia, or it is because of the starting of the immunosuppression, induction immunosuppression, or it could be a rebound hypertension, and could be because of inadequate pain control. So these are the causes of hypertension in the post-operative period. And one more thing we should know is that this donor allografts, they lack the ability to auto-regulate the blood flow. Thus, the systemic hypertension can result in inflammation and injury to the allograft endothelium. And second, you think that yes, the BP is too high, I need to control it. And if you control it very aggressively, then it might lead to hypoperfusion, acute tubular necrosis, and delayed graft function. Okay, so you should not even go for a severe hypertension or hypotension. There are no fixed guidelines to tell, yes, this is the BP that you need to maintain in the post-operative period. But there are some, hospital protocols which tell us that the systolic BP should be between 140 to 160. That would be an ideal one. Okay, so there are insufficient RCTs to support goal blood pressure, and also there are no guidelines for optimal pharmacological therapy in the perioperative period, that you have to give this drug only to reduce the BP. So that is not given anywhere. Okay, so suppose if the patient was on a beta adrenergic agonist or a clonidine preoperatively, you can continue this in the post-operative period also. But if the patient is on Dilsem, better to stop it, because it has a lot of drug-to-drug interactions with the immunosuppression drugs, which we will start post-operatively. Okay, and if you want to manage acutely the hypertensive emergency, then any IV drugs will be helpful. This is how you manage your hypertensive urgency or the emergency. Next, coming to the urine leaks. Okay, urine leaks nowadays is a rare complication. Okay, and it can arise from obstruction or distal ureteric ischemia, especially when the arterial blood flow to the lower renal pole is compromised. Okay, why did I tell it is a rare complication nowadays? Because before they were, when they were doing this anastomosis of the ureters to the bladder, it was a plain anastomosis. But now they're using stents also for the anastomosis or post anastomosis. Basically, they use stents, and this stents will actually prevent the urinary leaks. Hence, their incidence has been reduced recently. So usually these urine leaks, they may present with AKI, decreased urine output, and allograft pain. And how do you diagnose this urine leak? Basically by the ultrasound. So when you do an ultrasound, there will be some fluid collection, and the diagnosis is made when the fluid creatinine is elevated compared to plasma creatinine. So you see that there is some fluid collection, you can't keep it like that. So you have to insert some drain to remove that fluid collection. And when you insert those drain and the fluid comes out, you're going to send that fluid for the creatinine. And when you measure it, usually this fluid creatinine will be either equal or more than the plasma creatinine. Then you confirm that there is some urine leak. And how do you actually, the gold standard would be doing a cystogram or a nuclear scan or any antegrade nephrostogram. Okay, but these we won't usually do it. It is usually the ultrasound and then you insert a perinephric drain. Okay, so these urine leaks are managed initially conservatively with prolonged bladder decompression and continuation of this perinephric drain. But persistent leaks, they require surgical interventions. Now coming to the urinary obstruction. So why does this obstruction occur? It could be due to extrinsic compression from the fluid collections, or due to catheter blockages, kinking of a redundant ureter, or if there is a stone, prostatic hyperplasia, or devascularization resulting in urethral strictures. So all these are the causes of urinary obstruction in the post-transplant patient. So as the allograft is denervated, patients do not always develop some symptoms, especially the pain. They don't have much pain. There would be pain, but not so much. Okay, and usually this urinary obstruction will present with a sudden decrease in urinary output and AKI. So in such cases, you should flush the Foley's catheter to assess for obstruction, and imaging should be obtained to assess for any perinephric collection, stone, and or hydronephrosis. Okay, so how do you manage these patients? So initially, you try to decompress the collecting system either with a stent or a percutaneous nephrostomy tubes. Okay. Now the important one is the vascular complications which occur in the post-operative period. So one is the renal artery thrombosis and the renal vein thrombosis. So this renal artery thrombosis, it usually occurs within the first 3 days following the kidney transplantation. Okay, it is most oftenly seen in those patients who have a thrombotic tendencies or in those donor allografts with multiple renal arteries. In these patients, the chances of renal artery thrombosis is increased. So they usually present with sudden anuria, and the diagnosis is usually made by a drop Doppler where you see that there is no flow in the renal artery. Okay, so when you make the diagnosis, the immediate thing which you do is you have to do an emergent arteriotomy and thrombectomy. Okay, but most allografts with arterial thrombosis are usually lost. So it is a very emergency situation. So if you see there is a thrombosis, you have to do the thrombectomy. Otherwise, you may lose the entire kidney. Okay, so this is very important. Now coming to the renal vein thrombosis. Why can this occur? This is due to kinking of the renal vein or due to hypotension or acute rejection or if the patient has any hypercoagulable state. So this renal vein thrombosis can occur in two situations. One is intraoperatively, one is postoperatively. So how do you identify it intraoperatively? You see that the allograft will appear edematous and cyanotic if there is a renal vein thrombosis. So intraoperatively only you can remove the thrombus or do this is you can make something before you shift the patient outside, right? But if there is a delayed renal vein thrombosis which you have identified it in your post-operative period, okay, then the treatment would be thrombolytic therapy. But try with the thrombolytic therapy. If not, the better would be an emergent thrombectomy with revision of the anastomosis. Okay, prolonged ischemia will otherwise result in graft failure. Okay, so renal artery thrombosis is more dangerous than the renal vein thrombosis. Now coming to the iatrogenic vascular compromise. How would we cause a vascular compromise in this kidney transplant patient? So during surgery, the anastomosis, as I told, are made between donor renal vein and recipient external iliac vein and donor renal artery and the recipient external iliac artery. So important is recipient's external iliac artery. So whenever you are securing a central venous access in these patients, do not use the same side femoral vein. That is very important. So if you are doing a right kidney transplantation, don't use a right femoral vein. Okay, that is one important thing because prolonged venous cannulation has been associated with stenosis of the iliac vein, which can impair the allograft blood flow because usually it is anastomosed to the external iliac arteries and external iliac veins. Or any accidental formation of AV fistulas or large hematomas because of your procedure, it can compromise the allograft blood flow and results in vascular steal of the renal transplant. Okay. Now, the next important thing which we are worried in a renal transplant patient is infections because the patient is already on immunosuppression. So what are the most common infections? Who are at risk for these infections? And how do you manage these infections is the one which we'll speak in the further slides. So transplant related infections, they are common cause of ICU admission and it occurs in a predictable patterns depending on the post-transplant period and associated with high mortality rates. So these infections can occur due to technical issues of the transplant or due to donor-derived infections or as a consequence of our immunosuppression. Okay, so the most common transplant infection in the kidney transplant patients are first is the pneumonia followed by urinary tract infections. Okay, so because since these patients are on the immunosuppressive drugs, they will not be able to mount a proper response or the cultures might not be positive when you take it in a normal way. So better is to do some invasive procedures. Suppose if the patient has a pneumonia, then better to do a bronchoscopy. Or if the possibility is there, then do some biopsies or sampling fluid collections so that you can appropriately initiate the antibiotic treatment because the yield would be better. Okay, otherwise the patient, since the patient is on immunosuppression, they might not grow any bacteria or fungus. Okay, now coming to the unique risk factors for those patients who have undergone a kidney transplant. Okay, one is these patients require a high dose of maintenance immunosuppressions compared to other transplants. Second, because of the use of ATG, that is anti-thymosin globulin, which is used in the induction period of immunosuppression. I'm going to deal it later. So this is one of the thing. Third, plasmapheresis. If the patient undergoes plasmapheresis, why I will tell you later. Or if the patient has neutropenia and if the patient has an immunomodulatory viral infections. So these are the unique risk factors for infection in the post-kidney transplant patients. Okay, and most of these patients, they receive prophylaxis for CMV as well as PCP pneumonia for the first 3 to 6 months, because this is the time when these infections are more common in the post-transplant period. Okay, so this is one easy way. I mean, there are, many tables which tell a lot of thing about the infections, but I found this as a most concised one. So in the less than 1 month period, okay, what are the infections that you can see in the post-kidney transplant patients? One is there could be a recipient colonization because this patient might be on dialysis and there could be some CRBSA or CLABSI in these patients. Second, donor-derived infections. This could be bloodstream or any urinary tract infections. Technical complications, like if there could be any wound infections, anastomotic leaks, or any hospital-acquired infections like aspiration, line, or catheter infections. Okay, so these are most common in the first month post-transplant period. Now, what happens in 1 to 6 months, where you have a maximum immunosuppression which is going on? So, most common infections would be viral infections and some opportunistic infections. In viral infection, HSV, CMV, VZV, EBV, adenovirus, influenza, BK virus, and hepatitis viruses are more common. In opportunistic infection, fungal infections, especially the PCP, Aspergillus, and Cryptococcus, Mycobacterium tuberculosis, listeria infections, nocardia, and toxoplasma are more common opportunistic infections in 1 to 6 months. Post 6 months, what could be the most common one? One is it could be a community acquired pneumonia, any UTIs, late viral infections, and late opportunistic infections. Okay, so this has to be, when they ask about infections, you have to put this diagram. Okay. Now, as I told, the most common infections are the pneumonias followed by UTIs, right? So, lower respiratory tract infections are the leading cause of admission to ICU in the kidney transplant recipients. The most common is the bacterial pneumonias, the most common organism being E. coli and the streptococcus. Okay. So, the next most common opportunistic infection is the PCP pneumonia in these patients. Now, coming to the urinary tract infections. So, what are the risk factors for the post-transplant recipients? One is because of the presence of urethral stents. I told before that when you anastomose the ureter to the bladders, they're usually using the stents nowadays. So, any presence of urethral stents and the anatomical positioning of the transplanted kidney is also important, because if there is any chances of shorter ureter, if there is any lack of anti-reflex properties, or if there is any denervation, that may lead to delayed diagnosis. Okay, the most common organisms are E. coli and Klebsiella, but nowadays, because of increased incidence of MDRs, even Enterobacteriaceae and Pseudomonas are becoming more common organisms for this UTIs in kidney transplant recipients. And in fungus, Candida is the most common cause. Acute graft pyelonephritis is one of the independent risk factors for persistent decline in renal function and graft loss in these patients. Okay, if suppose you, for these urinary tract infections, you have started antibiotics, but the patient is not responding, then please look for any abscesses, because these patients have undergone a transplant, a post-operative period, some collections might lead to abscesses. So you require some additional imaging, especially CT, if the patient is not able to respond to your initial antibiotic therapy. Now, viral infections, as I told, the most common would be the CMV. The incidence is around 40 to 80% in the kidney transplant recipients. What are the risk factors? So, if the transplantation is done from a seropositive donor, or if the patient is on anti-thymoglobulin therapy, if the recipient's age is advanced, that is more than 60 years, or if the patient has a lymphopenia and on mycophenolate therapy, these are the risk factors for CMV infections in these patients. So what is the treatment? You either give an IV ganciclovir or a oral van ganciclovir if the patient has a mild disease without any gastrointestinal involvement. But if the patient has a GI involvement and has a refractory CME viremia, then you should use second line drugs such as foscarnet and pseudofovir. Now, just a note on early graft dysfunction. Now, we'll see what are the causes of the early graft dysfunction. It could be a medical cause or it could be a surgical cause. So, what are the medical causes for early graft dysfunction? It could be acute tubular necrosis of any cause, acute rejection, or any recurrence of the kidney disease. Now, what are the surgical causes? It could include hemorrhage, any thrombosis of arterial or renal artery or renal vein, any other vascular complications like aneurysm or renal artery stenosis, and urological complications like ureteral stenosis or urinary leaks. Just a note on acute rejection. So I've been mentioning about acute rejection, acute rejection. So what is this acute rejection? It is nothing but an immune response against the donor graft that causes tissue impairment and potential failure. It is usually the rejections are diagnosed by kidney biopsy. And this acute rejection is divided into two, either cellular mediated acute rejection or antibody mediated. So cellular mediated is basically the lymphocytic attack against the donor tissue. If it is a cellular mediated and you have diagnosed it on the kidney biopsy, the treatment would be steroids or thymoglobulin. But if it is an antibody mediated acute rejection, then the treatment would be plasmapheresis or IVIG. Okay. Then we've now finished about the infections. The next important thing is about the immunosuppression. So what is basically transplantation? Transplantation refers to the transfer of a tissue or an organ to the same person, which is known as autologous transplantation, or to another person, which is known as allogenic transplantation. So when you do transplantation, there should be some major histocompatibility complex matching which has to occur. Correct? If it doesn't occur, then there is an increased chances of risk of organ rejection. Okay. So this MHC, okay, this MHC compatibility, okay, it should be matched nearly 80 to 90%. The 100% matching can occur only if there is an identical twin, that is twin to twin transplantation of kidney. There will be 100% MHC matching. But in other patients, that much of matching is not possible, right? So there is more chances that the organ might get rejected. So in order to prevent this, we use immunosuppressive therapy. So as I told, the transplantation of antigenically foreign tissue or organ, it is associated with activation of cascade of immune mechanisms in the recipient, which are aimed at rejecting the organ or the tissue. So there are three types of rejection. One is hyperacute rejection, and chronic rejection. So hyperacute rejection, it occurs within minutes to hours after transplantation, and it is caused by pre-existing donor-specific antibodies in the recipients, which recognize those antigen in the transplanted kidney. So how can this pre-existing donor-specific antibodies be present? So it can happen due to prior sensitization of the patient from the blood transfusions, or if the patient was a pregnant lady, or if the patient had a previous transplantations. Okay, in such cases, if the recipient has some specific antibodies to the donor, then there could be rejection that is known as hyperacute rejection. Okay, so this type of rejection can cause irreversible damage to the graft, leading to graft necrosis and failure. Okay, it is extremely rare now because there is an universal adoption of pre-transplant cross-matching techniques which has been done very stringently. Okay, so hyperacute rejections have become now little rare. So acute rejection I've already discussed. So it occurs within the first week to 3 months after transplantation, and it can arise from different immunological mechanism, that is nothing but the cell mediated or antibody mediated. Now coming to the chronic rejection. Okay, so this occurs months or years after transplantation. Okay, the major contributors for this chronic rejection could be, okay, it is mainly from the non-immunological factors, especially the nephrotoxicity due to long-term exposure to calcineurin inhibitors, or viral infections or cancer due to treatment of induced immunosuppression. So basically, it is because of the complications of the immunosuppression which we give to the patient. Okay, there is currently no cure for chronic rejection other than removing the graft. Okay, so this is about the different types of rejections. Okay, now coming to the classes of immunosuppressive drugs. Okay, so there are 5 classes. Okay, the first one is the most common which we use is the calcineurin inhibitors, which include either cyclosporin or tacrolimus. So in kidney patients, we usually use tacrolimus. The second one is the mammalian target of rapamycin inhibitors. What are those? Those are sirolimus and everolimus. The third group are the anti-proliferatives, which are the azathioprine and the mycophenolic acid. So we use usually mycophenolic acid in our kidney transplant patients. The next, glucocorticoid steroids, yes, this also we commonly use. And the fifth one is the biological immunosuppressive agents. Now we go through each one of it, not in detail, uh, at least one slide about each drug we'll be discussing. Now, as I told, this immunosuppression is divided into two. One is the induction therapy, one is the maintenance therapy. So the induction therapy is usually given by the biological agents, the fifth group. Okay. So induction drugs can inhibit the lymphocytes or prevent their activation and replication. And this is usually done by IL-2 receptor antagonists or the anti-thymoglobulin. So I think most of the hospitals use the anti-thymoglobulin as the induction therapy. Okay. So the most common induction agents in kidney transplant patients are basiliximab, alemtuzumab, and the ATG, that is the anti-thymocyte globulin. Okay. So other biological drugs would include eculizumab, belatacept, and the rituximab, which are often used in specific clinical condition. If there is a graft failure or all, I'm not going to discuss it in detail, but at least you should remember that the biological agents are used for induction therapy, and the most commonly used are basically the IL-2 receptor antagonist and the ATG. Okay. Now next comes the maintenance therapy, where you use the other remaining 4 group of drugs. So in that, the first one is the calcineurin inhibitors. So this calcineurin inhibitors include what? The TAC A and B. Okay. So just a second. So coming to the mechanism of action of this calcineurin inhibitors. So the major action is these inhibitors, they blunt the immune response by inactivating something known as calcineurin phosphatase activity. So this is one of the enzyme which is actually used for translocation, dephosphorylation and translocation into the nucleus, and basically it helps in the transcription of the DNA. This enzyme is used. Okay. But when you use this calcineurin inhibitors, these calcineurin inhibitors go into the cytoplasm of the cell and they bind to something known as cytosolic protein called immunophilin. Okay. So this inhibitors, they bind to immunophilin and they form a complex. This complex will go and attach to the enzyme which I have mentioned. That is nothing but the calcineurin phosphatase enzyme, which has 2 components. It has A component and the calcineurin phosphatase A and B. So when it binds to this. So what does it do? Okay, it inhibits a transcription factor which is named as NFAT. Okay, what is NFAT? It is nuclear factor of activated T cells. So this will inhibit this NFAT, which is usually involved in dephosphorylation and translocation of the nucleus. Okay, so when this inhibits, this dephosphorylation and translocation will not happen, leading to blockage of IL-2 transcription. Okay, this is how these calcineurin inhibitors act. Need not to remember the mechanism, but just to remember. Okay, so as I told, tacrolimus is the most commonly used calcineurin inhibitor. So it is 100 times stronger than the cyclosporin A. Okay, so it's usually undergoes extensive metabolism in the liver and has less than 1% excreted into urine. And to a much lesser extent, metabolism also occurs in the intestinal mucosa, which is mediated by the CYP3A4. Okay, the bioavailability of tacrolimus is 90% depending upon the individual, and for this reason it is difficult to predict the optimal starting dose, and hence the adjustment of the maintenance dose is that depends on the trough levels. Okay. Now coming to the side effects. Okay, so cyclosporin and tacrolimus. Cyclosporin has hirsutism, or it causes hirsutism, gingival hyperplasia, and hypercholesterolemia. Whereas tacrolimus causes the opposite, alopecia. It has lots increased risk for neurotoxicity, and it causes pancreatic islet cell toxicity leading to glucose intolerance, and it has some GI disturbances. And both together has nephrotoxicity, has increased chances of hypertension, gout, hyperkalemia, and hypomagnesemia. Okay. Now comes the second group of maintenance drug, that is the mammalian target of rapamycin inhibitors, which include sirolimus and everolimus. Okay. So what is the mechanism of action of these drugs? They basically inhibit T and B cell proliferation and differentiation. They inhibit the antibody production, and they inhibit the proliferation of non-immune cells like fibroblasts, endothelial cells, hepatocytes, and smooth muscle cells. They are rapidly absorbed after oral administration, and when taken with food, their bioavailability is affected. That is, their bioavailability will be decreased on taking the food. So they should be taken on empty stomach. The most common side effects of these drugs are it causes pneumonitis, it causes thrombotic microangiopathy, can cause surgical scar infections or late healing, lymphocele, productive surgical drainage, post-transplant diabetes mellitus, hypertriglyceridemia, hypercholesterolemia, proteinuria, and peripheral edema. Now coming to the anti-proliferatives like azathioprine and mycophenolic acid. So azathioprine, as we all know, it is a purine analog which mediates its effects by preventing the synthesis of nucleic acid. So basically it inhibits activation, differentiation, and proliferation of lymphocytes, and it reduces the activity of the NK cells. This is how it acts as an anti-proliferative. Now coming to the mycophenolic acid, usually this is commonly used in kidney transplant patient. So basically it is available in two forms. One is the mycophenolate sodium and mycophenolate mofetil. So we usually use mycophenolate mofetil. Okay, so basically it is a reversible and incompetent inhibitor of the enzyme, something known as IMPDH. So what is the importance of this enzyme? It helps in the de novo guanine synthesis and DNA replication. But when this enzyme is inhibited, there won't be any guanosine synthesis and DNA replication, and hence it blocks the proliferation of the T and B cells. And the last one is the glucocorticoids. The two commonly used glucocorticoids in renal transplant patients are the methylprednisolone and prednisolone. So they exhibit anti-inflammatory and immunomodulatory effects in addition to their immunosuppressive effects. So coming to, there are different protocols which has been practiced in different hospitals. So this treatment actually needs to be personalized, okay? And it depends on many of the factors, like what is the donor type, whether the donor is a living or a deceased donor, what is the HLA matching of this patient, what is the organ quality, donor age, recipient immune risk, comorbidities, and possible infections. So it depends on all these factors, and then the nephrologist will decide on which protocol to be started. But currently we use the triple drug therapy, which usually contains the calcineurin inhibitors, corticosteroids, and the anti-proliferative drugs. Okay. In addition, you have the antibodies which are used in the induction therapy. So in conclusion, so we usually use ATG for the induction therapy, and for the maintenance therapy, tacrolimus plus mycophenolate plus a methylprednisolone. This is usually the commonly followed protocol in our hospital, most probably in other hospitals also. Now, coming to the complications which are associated with usage of immunosuppressive drugs. So we happily use immunosuppressive drugs, but there are a lot of complications which are associated with this. The first one would be steroid-induced post-transplant diabetes, hypertension, and hyperlipidemia. And these immunosuppressive, if you take long-term immunosuppressive drugs, there is a chance that patient might have cancer. Okay, so cancer is the second most common cause of death in kidney transplant patients, especially on a long-term immunosuppressive therapy. The most common cancer which occurs are, one is the renal cell carcinoma and the second one is the skin cancers. The most common skin cancer are the cutaneous squamous cell carcinoma, basal cell carcinoma, Kaposi's sarcoma and malignant melanoma. And this is most commonly seen with the calcineurin inhibitors. Coming to the viral infections, okay, EBV, CMV, BK polyoma virus and norovirus are also most common viral infections in immunocompressive drug patients. You have other infections like bacterial infections, invasive fungal infections. Okay, and there could be chances of thrombotic microangiopathy, TMA, in patients with long-term calcineurin inhibitors and the rapamycin inhibitors. And press is more commonly seen with patients of calcineurin inhibitors, especially when you start induction therapy. I mean, maintenance when you start, right, immediately. So it causes hypertension, right? The most common adverse effect with CNIs are the hypertension which it causes. So it may lead to press. And this mTOR, that is rapamycin inhibitors, may lead to pneumonitis, fibrosing alveolitis, and pulmonary hemorrhages. Basically, they involve the lung. So this is one small table which tells about the different drugs which we use commonly. So coming to the immunosuppressive effects of the drugs, okay, which has better potency, it is the cyclosporine, that is the CNIs, okay. Cyclosporine inhibitors have, sorry, calcineurin inhibitors have a higher degree of immunopotency compared to the other drugs. Coming to the nephrotoxicity, it is more with calcineurin inhibitors. Neurotoxicity also is more with calcineurin inhibitors. Coming to the hirsutism or trichosis, most common with cyclosporine. Coming to the diabetogenicity, post immunosuppression diabetogenicity is more common with tacrolimus and steroids. Diarrhea is more common with MMF, and hepatotoxicity is more common with sirolimus. And bone marrow suppression is caused by sirolimus and mycophenolate. Okay, so these are the common side effects and the immunosuppressive potency which is mentioned in this table. Now, as I told, most of these immunosuppressive drugs are metabolized by this cytochrome P450 enzyme, particularly the CYP3A. So we should be more careful that a lot of drug-drug interactions can occur with these drugs. So when you are using any other drug, please see before whether this has any drug induction or inhibitor effect. Okay, because there could be some supratherapeutic levels may cause toxicity and subtherapeutic levels may lead to rejection of the uh, organ. Okay, so better is to measure the trough levels. So the CNIs and rapamycin inhibitors, they actually you should monitor the trough levels. Ideally, it should be 3 times, minimum at least 3 times per week. And you have to measure it daily after you do some dose adjustment or if you're initiating any other drugs. Okay, like any other CYP3A inhibitors or inducers, then you have to measure it daily. Okay, so trough levels are very important. Now, coming to the doses of the drugs. So just remember about 3 important drugs, as I told, tacrolimus, mycophenolate, and prednisolone. So tacrolimus, the most common dose is 0.1 to 0.15 mg per kg per day. It is given as a BD dose, okay, divided doses. Then coming to the prednisolone, methylprednisolone, and mycophenolate. Actually, it is variable in different individuals, but commonly which we use, I'm going to tell. So mycophenolate will be usually started as 500 to 1000 mg in a BD dose. And prednisolone, basically methylprednisolone is used. It is used as 5 to 7 mg per kg body weight. Okay, that is a starting dose of methylprednisolone in post-transplant patients. At least you have to remember these 3 doses of the drugs. Okay, and the last slide which tells about the long-term management of this kidney transplant patients. So finished transplantation is done, they can do anything? No, nothing. There are certain goal of treatment which they have to follow post-transplantation. One is hypertension. So if the patient has an hypertension, they have to maintain their BP below 130 by 80 mmHg. Okay, so this can be done by lifestyle modification or by using a calcium channel blocker, AC inhibitors, or a beta blockers if the patient have a underlying cardiovascular disease. Better to avoid dilsym or verapamil because I told there are a lot of drug-to-drug interactions with the calcineurin inhibitors. Second, how should they control with the dyslipidemia? So their total cholesterol should be less than 200, their LDL should be less than 100, and triglycerides should be less than 150. Either use the lifestyle modifications or use statins, fibrates. Okay, and you should be very careful that when you're using the statins plus fibrate, more chances of hepatitis, myositis, and rhabdomyolysis will be occurring. So you have to monitor all these things. Then what is this NODAT? That is nothing but the new onset diabetes after transplantation. This could be secondary to your immunosuppressive drugs which you are using. So you have to target the HbA1c between 7 to 7.5. Okay, next, anemia. Yeah, CKD patients have more chances of anemia, but you have to maintain the target HB here in post-transplant as 11 to 12 gram per DL. If required, either intravenous or oral iron should be given, and you have to use recombinant erythropoietin. Okay, if the patient is obese, they have to keep their BMI between 35 to 40. And if there is a tobacco abuse, you have to stop smoking or tobacco chewing. Okay, thank you. I hope most of it is clear. If you have any doubts, please post it in the chat box. Srihari, are you there?
Yes, ma'am. I'll take over, ma'am.
Oh,
Thank you.
okay.
Is the screen visible, ma'am?
Oh, Srihari?
Is the screen visible?
No, no.
Not yet. Okay, one just a second.
Ah, okay.
How about now,
Yeah, now
ma'am?
visible. Now visible.
Okay. 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 Good evening to everyone. So today I'll be having two topics for discussion. One is critical care management of liver transplant recipients, and the other one is on quality indicators. So, ma'am had already discussed very much in depth regarding immunosuppression and infections. So, that part of it is kind of clear to most of you, I hope. So, I'll be discussing components of liver transplant recipient management from more of an exam perspective, because you guys just have another 1 month left. So, I don't want to give too much of knowledge. So, I just thought I'll just give you important pointers of how and what you need to write in the exams. So before we go into the topic proper, I just thought I'll give a small introduction just to make it a little interesting. So just coming to the introduction regarding liver transplant in India, the first disease donor liver transplant, as well as the first successful living donor transplant, were performed only in the 90s. That is 1998 in India. So in the first half of the decade, that is between 2000 to almost 2010, the outcomes were not good in following liver transplant. And up till 2004, only about 130 transplants were done at that time. But in the last decade, that is from 2010 till now, there has been a very significant growth pattern in the number of cases that have been done so far. In North India, especially Delhi, it has been the seat of growth of live donor liver transplant. And in South India, especially Chennai and Hyderabad, it has played a very key role in establishing disease donor liver transplantation in the country. So, as of now, there has been an estimate of almost 7,500 transplants that have been done, and that approximately 80% are living donor and the remaining are disease donor. So, coming to the topic, the main purpose of ICU management after liver transplantation is, besides the general management that is applied for all major abdominal surgeries, with regard to liver transplant, you need to look for hepatic complications and look for problems related to immunosuppression. So, these are the main two areas which you'll have to look into when you manage a post liver transplant recipient. So, just brushing through the pre-transplant and intraoperative management. So, pre-transplant evaluation. So, what are the indications? So, if you are looking at a patient with CLD or a patient with cirrhosis, The common indications are those who have a history of an NAFLD, that's non-alcoholic fatty liver disease, but now it is called as steatotic liver disease. That NAFLD term has now gone off. Now it is more of SLD, steatotic. And along with that, chronic viral hepatitis, either B or C, autoimmune liver diseases that can be either primary biliary cholangitis, primary sclerosing cholangitis, or an autoimmune hepatitis. Any of these conditions, if at all there is a decompensation occurring progressively, that becomes an indication. And hepatocellular carcinoma can be considered for transplantation, provided it fits into this criteria. Now, there are almost 10 to 15 criteria for transplant in a HCC patient. But from an exam perspective, I think this one name is, I think, sufficient for now. It's called Millen criteria, and they have this saying that is less than one lesion should be there, which should be less than 5 centimeters, or less than 3 lesions, less than 1 centimeter. Sorry, I have written it as less than 3 lesions itself. It is less than 1 centimeter, and there should not be any vascular invasion or extrahepatic metastasis. So, if all these criteria are satisfied, then the patient with HCC can be considered for a transplant. Then for acute liver failure, as most of you would be knowing because you are in the exam preparation phase, just for revision purpose, I've just put it up. For paracetamol-induced ALF, you have a single criteria of arterial pH less than 7.3 despite fluoride resuscitation, or all of the three. That is INR more than 6.5, creatinine more than 3.4, or grade 4 or grade 3 and hepatic encephalopathy. For non-paracetamol induced ALF, a single value INR more than 6.5 or PT more than 100 seconds, or any 3 out of the 5, that is non-hepatitis A or B, drug-induced or indeterminate etiology of ALF, time from jaundice to encephalopathy time more than 7 days, if the age is less than 10 or more than 40, prothrombin time more than 50 seconds, that is INR more than 3.5, and serum bilirubin more than 17.5. So only one thing I want to emphasize is bilirubin as a criteria comes in only in the non-paracetamol induced ALF. It does not come under the paracetamol induced ALF. So when you think from the exam perspective, when you're writing your answers, there may be a small confusion. So for paracetamol, it's only INR, creatinine, and hepatic enceph. Whereas for non-paracetamol, bilirubin comes in along with the other 4 parameters. So we saw the indications. So there are also contraindications. So absolute contraindications, as of now, what they say is untreated HIV, severe irreversible pulmonary disease, ongoing alcohol misuse, illicit drug abuse, ongoing extrahepatic sepsis, active or previous extrahepatic malignancies, and liver cancers that are outside of this criteria. And relative contraindications are inadequate social support, smoking, anatomical variants in the liver structures, BMA more than 40, or previous extensive abdominal surgery, like a Roux-en-Y procedure that was done, where there may be total alteration in the anatomy. So now, in the upcoming years, in the last few years, there has been a small trend shifting towards newer indications for transplant. Now they say patients, like patients who present with an acute liver failure, when they do present with an acute or chronic liver failure, that is, they manifest with jaundice, ascites, variceal hemorrhage, or hepatic encephalopathy, those patients can be considered for transplantation. Similarly, patients with cholangiocarcinomas, perihilar or intrahepatic, can be considered. Now they say alcohol-related liver disease and alcoholic hepatitis patients can also be considered for transplant, because the concept, what they say is, rather than the patient developing severe hepatitis going into a very bad decompensation, if they are in the hepatitis phase with mild CLD changes alone, their recovery is supposed to be better compared to those who tend to present in the later phase. But like we always have an idea, they have to be in abstinence for a period of 5 to 6 months at least. And the other two are neuroendocrine tumor metastasis and colorectal carcinomas with liver metastasis. Now, all these areas may sound controversial, but they are upcoming indications and they have certain criteria. under which they can be taken up for transplant. Like I said, for HCC, under the Milan criteria, they have said if one lesion is there, this is the amount of centimeters that should be, sorry, millimeters that should be there. And if there are 3 lesions, there should be this much of size should be there. And there should not be any invasion or any other metastasis. So coming to the intraoperative care, now transplant surgery is divided into 3 parts. That is prehepatic, anhepatic, and posthepatic. So coming to the prehepatic phase is just mobilization of the diseased liver in preparation for its removal. Then we have the anhepatic phase. So that is characterized by progressive coagulopathy and a decrease in venous return to the heart. Why does that occur is it is secondary to clamping of the IVC. So methods that can be done to circumvent this problem is you can either go with a veno-venous or a portovenous bypass that can be used to avoid significant hemodynamic changes and decrease the bleeding. So after the native liver is removed, the donor liver is placed in an orthotopic position and then the IVC anastomosis are sewn. So this is about the anhepatic phase. Then comes the post-hepatic phase. So this begins at the time of reperfusion. So most of you might have heard about this. During the time of reperfusion is the time when the patient undergoes a very catastrophic course. There can be severe hypotension, there can be severe pulmonary hypertension, and there can be a lot of arrhythmias. So this hemodynamic changes can occur due to various causes. Acidosis, dyslipidemias, that is potassium can either go up or go down, or there can be severe fluctuations in your calcium levels. Then there can be air embolus that can occur, or there can be volume overload. Because the initial phase itself, there could have been a lot of products that could have been given that can affect the cardiac status. So during this phase, close monitoring with appropriate volume resuscitation and electrolyte management is critical. And during this phase, there is hemostasis and completion of the biliary anastomosis. So this part of the management is usually done by the transplant anesthesia team. So they usually take care of it. Our role is relatively small, but we do need to know what all the problems or the issues that had happened intraoperatively because that is going to affect the post surgical phase. So coming to the post-operative management, the post-operative course depends on the patient's preoperative status and the development of any complications. So these two factors determine how the patient is going to come out. If there are not going to be any issues preoperatively and the intraoperative phase goes very smoothly, usually the post-operative course is very, very calm. There is not much of issues that are usually anticipated. So coming to the post-operative management, you can classify it into 3 parts. One is basic care, surgical issues, and non-surgical issues. So whenever you see a patient post-transplant, you always have to look for surgical complications and non-surgical complications. So whenever you get to see a patient with like any recipient patient for that matter, whether it's renal, liver, lung, cardiac, you have to assess the patient from a perspective of complications rather than how you see a normal ICU patient, because you always have to keep looking for complications, because any small complication in a recipient is going to increase morbidity and can even lead to mortality if it is not picked up on time. So that is why they keep emphasizing the importance of knowing about the complications and how to go about it. So coming to the basic care, it's ABCs. Once you receive the patient from the OT, you take an ISBAR. That is like you have to take the handover. Then you assess the ABCs and you optimize it. So if any hypotension is there, you go ahead with fluid resuscitation if it is needed. Definitely advanced hemodynamic monitoring will be needed. So fluid resuscitation in most liver transplant patients, they go with the combination of crystalloids and colloids. So colloids, they usually go with albumin. So with regard to fluid management in transplant patients, there is no hard and fast rule per se, or there is no fixed guidelines. It is at the discretion of every hospital. So they usually have their own protocols and they go according to that. So in most centers, especially in Coimbatore, when I was previously in PSG, they used to give it as a balanced crystalloid. They usually keep plasmalite or sterophundin, and along with that, they used to keep 5% albumin. So they used to titrate the colloids and crystalloids based on the hemodynamic status and make their decisions on fluid management. And vasopressors, we need to titrate it, as you know, to a map of 65 to 70. That's based on the comorbids also. And along with this, the FastX bit has to be always be mentioned. So in paper 2, invariably, most of your questions are going to be related to management questions. So you will have to mention it as specific and basic critical care. So when it comes to basic critical care, make it a point to mention about this FastX bit. So along with this, like I said, you need to monitor for evidence of improving graft function. So pertaining to liver, you need to look at the mental status and coagulation profile. You have to look at the sugar trend, the clearance of serum lactate, and the transaminases and bilirubin. So this monitoring has to be done on a regular basis. Most ICU setups, transplant ICU setups, they usually monitor it between every 6 to 12 hours on a regular basis to assess the trend. And provision of adequate immunosuppression. I will come up about it in my subsequent slide. Vigilance, surveillance, and management of early complications. So this is what I said. You need to know what are the surgical issues that can be anticipated and the non-surgical issues. That's the medical related issues. So at least 5 to 6 complications should be at the back of your mind whenever you see these patients. And infection prophylaxis and treatment. So Niharika madam had very beautifully explained about the transplant related, post-transplant related infections that are likely to occur at various timelines. So with regard to liver, you need to adapt the antibiotic choices, prophylactic antibiotic choices based on the patient's preoperative flora and the immune status. Antifungal prophylaxis are to be added in high-risk patients, and most common infections that occur in post-transplant patients are pneumonias. So in cases of suspicion of infection in transplanted patients, broad-spectrum antibiotics should be initiated early and readapted to the results of the bacteriological samples. So this is something we already know, just emphasizing on this. So most setups, they usually start with carbapenems, they start with teicoplanin or vancomycin, and they start with antifungals. They go directly with either a drug like anidulafungin. So this is usually the combination they keep, but like I said, each transplant center has their own variation and their own protocols. And the most important thing is avoidance of common pitfalls. Because in anesthesia, there is a saying, you do one mistake, you are spared. But when you do two mistakes, there is some big complication or catastrophe that is going to happen. In transplant recipients, there is no error for a second mistake also, because even a small mistake is going to create a big blunder. So it has to be taken care very prudently. So you need to avoid common pitfalls. So over sedation with benzodiazepine and narcotics should be avoided. Unaddressed hypotension should always be avoided because it can contribute to AK and it can lead to graft thrombosis. And if the patient's sodium trend is low initially, you don't have to go very aggressively about it, because aggressive treatment can lead to demyelinating syndromes, and that itself is going to create a bad prognosis, and it's going to spoil the purpose of transplant that had been done over a long period of time. And in addition to this, another important component is infection control. So infection control practices have to be very stringent whenever you manage transplant patients, be it any form of transplant, liver, kidney, cardiac, lung. It has to be done very meticulously. So coming to immunosuppression, main rationale is primary immunosuppression must be implemented immediately after liver transplant to prevent several clinical forms of rejection, which includes acute T cell mediated rejection, acute antibody mediated rejection, and chronic rejection. So one thing I wanted to emphasize is, most of the time you would have heard about transplant rejection, transplant rejection, transplant rejection. There are totally only 3 types of transplant rejection which we need to know. One is T cell, one is antibody mediated or B cell, and other is the chronic rejection. So, like previously, madam had told, once patient goes into chronic rejection, the scope of further salvageability is very, very low. So, with regard to liver transplant, there are only 2 things you need to really keep in mind. The commonest regimen that is used is you go with the calcineurin inhibitor. In most of the centers, they go with the tacrolimus. And the second is to go with corticosteroids. So it's as simple as that. So if at all they ask you about immunosuppression, you go with the CNI and you go with corticosteroids. These are the main drugs that are used in liver transplant recipients. So corticosteroids are part of most immunosuppression protocols with progressive tapering to discontinuation. So initially, during the anhepatic phase itself, many of them do administer steroids, and they usually give it as pulse steroids. Like around 1 gram is given, usually about 3 to 5 days, and then over a period of time, based on the clinical status, it is then tapered accordingly. Now, usually the tapering is done over 3 to 6 months, but there are certain conditions where you need to give it lifelong. And one among them are in autoimmune liver disease, that is either PBC, PSC, or autoimmune hepatitis. In all these subset of patients, you need to continue them on lifelong steroids. So the two important CNAs that you know are TAC and cyclosporin. So for TAC, the important thing is, like previously Madam had told, the maintenance dosing is the concern. The loading dose is quite straightforward, 0.1 to 0.15 milligram per kg per day divided 12th hourly. And it is given in the initial 6 hours post-transplant. So they say that you have to go with the maintenance dose based on the trough levels. So in the first month, they target 7 to 10, and thereafter they target 4 to 8. So that is the easiest way to mention it. So 0.1 to 0.15 milligram per kg per day, divided doses, and given within 6 hours of post-transplant. And rough levels, within the first month, it's 7 to 10 nanograms per ml, and thereafter it is 4 to 8. Whereas for cyclosporin, 4 to 12 hours pre-transplant, you need to give it as 15 milligrams per kg for one dose. Then 1 to 2 weeks, you give it BD in divided doses. That same 15 milligram per kg per day is given in divided doses. And then you reduce it 5% per week till you get it to 5 milligrams per kg per day in divided doses. If you are able to understand it, it's well and good. If you don't, it's not a problem. At least tacrolimus dosing should be well kept in mind, because that is more important, because cyclosporin is not very commonly used in the liver transplant setting. Tacrolimus is very, very important. It needs to be known. So with regard to side effects, there is a wide variety of side effects, and it's very difficult to remember all of them. But what I would emphasize is to concentrate on these. One is renal impairment, because if renal impairment is there, TAC dosing needs to be adjusted. So that's when you will have to consider a second immunosuppressant medication. So it's very important to know about the side effect of renal impairment. So nephrotoxicity is one. Hypertension is one, because calcineurin inhibitors itself are prone to cause posterior reversible encephalopathy symptoms. So that occurs because of very, very high elevated blood pressures. Though normotensive patients can develop this, that's a very, very atypical manifestation, and it is very, very rare. And glucose intolerance. So these three are very, very important, because, like I said, in a post-transplant or post-surgical patient, for that matter, hyperglycemia itself is known to worsen outcomes. And corticosteroid side effects, I've just mentioned it for memory, for just like refreshing your mind. So the common side effects are hypertension, fluid retention, infections, myopathy, muscle weakness, bruisability, altered mood, peptic ulcerations, and that itself can precipitate pancreatitis. So these side effects need to be kept in mind. At least 5 to 6 side effects need to be known in relation to your immunosuppressants. So mycophenolate. Mycophenolate is supposed to be a very important drug with regard to renal transplant. Usually they have a triple regimen. In that, mycophenolate is one among them, but in liver transplant, it is not now recommended in the initial liver transplant. It is usually considered as an alternate regimen, but it is not usually commonly used most of the time. Azathioprine, that is the antiproliferatives. Azathioprine was initially, during the initial days, that is in the 80s and early 90s, it was used as the first line drug along with steroids, but it was associated with high rejection rates. They say that rejection rates were as high as 22 to 25%. So that's a very, very high number. So that was the reason it had been replaced by calcineurin inhibitors. So the other set of drugs, like we had discussed, are the mammalian target of rapamycin, that is the mTOR inhibitors. So they can be used as alternatives to calcineurin inhibitors if there are any complications or side effects associated with it, or if there are inadequate dosing and the dose can't be increased due to certain reasons, then this can be added as a second line drug along with TAC. So the advantage is you give a lesser dose, you maintain the trough concentration, but at the same time you avoid unnecessary complications. So the two drugs that are used are everolimus and sirolimus. So with regard to this, the important side effects that you need to know is these drugs are prone to cause hepatotoxicity and bone marrow suppression. So the problem with bone marrow suppression is, if at all it occurs, you will not know whether it is because of drug or whether there is a new infection that has occurred. Because in the patient who is immunocompromised, they have various ways they can manifest, and they don't have to have fever to show you that they're having an infection. So if at all there is marrow suppression, that also could indicate a fever. And this factor could be confounded if at all the patient is on these set of drugs. So we covered the basic issue, basic management. We gave a small idea about the immunosuppression. So what I mainly wanted to emphasize is the main drugs you need to use are CNA, that is a calcineurin inhibitor. In that, tacrolimus is the most important drug that is commonly used. In the EASL guidelines also, tacrolimus is what they are emphasizing on. So you give it at a dose of 0.1 to 0.15 milligrams per kg per day, divided doses. The first month trough level should be between 7 to 10. Subsequent, it is 4 to 8. And alternative is cyclosporin. And steroids have to be given initially in pulse. Usually it's given in pulse, and then it is tapered over 3 to 6 months. Then, if the patient is having an autoimmune hepatitis, then it is continued lifelong. So this is about it. Then this mTOR inhibitors, that is everolimus and sirolimus, are usually given as alternative agents or second line in addition to your CNAs. Mycophenolate is not given. It is as initial agent. It is only an alternative agent, but it is not commonly preferred. And azathioprine is out of practice in relation to liver transplant recipients because of its high risk of rejection. Another thing I wanted to emphasize again over there was infection control is a very, very important factor. So when you write about the initial management in your basic management, along with immunosuppression, infection, antibiotic prophylaxis, infection control also has to come. So the next part is related to surgical issues. So the commonest complication that we anticipate post-surgery, any kind of surgery, is hemorrhage. So post-operative bleeding is common, and it is exacerbated by coagulopathy, fibrinolysis, thrombocytopenia, and platelet dysfunction. All this can occur in a patient who is having a dysfunction of the liver. So the signs of ongoing blood loss, most of you know, hypotension and tachycardia, decreased cardiac filling pressures, a fall in hemoglobin trend, or an increase in surgical drain output. So most of these can be identified clinically. Plus, in most of the patients, we will be having advanced hemodynamic monitoring. So that is in most of the transplant ICUs. So that those parameters that are available also will be able to guide you in identifying if the patient is going into a hemorrhagic shock or any other hypovolemic shock. Hypovolemic shock in this setting is most commonly because of hemorrhage. So one of the ways you can assess for hematological functions, that is coagulopathy, fibrinolysis, or thrombo or platelet dysfunction, is to go with the TEG or ROTAM. So Darshan done a talk on this. So I would personally recommend you to look into that in case you don't have much of an idea on TEG. And surgical exploration is indicated if bleeding persists despite correction of your coagulation deficiencies. So the next important complication you need to look are into the vascular complications. So in the early transplant phase, thrombosis is the main problem. In the later phase, it is more of strictures or stenosis. So thrombosis is the commonest event that occurs in the early phase. Stenosis and pseudoaneurysms occur in the later part. So Doppler ultrasound evaluation is the imaging modality of choice. So if at all you have worked in that ICUs, invariably most of the transplant surgeons post-operatively or the next day, they will ask the radiologist to come and immediately have a Doppler assessment because they need to know about the flows, whether it is reduced or it has increased. Because if the flow is reduced, that increases the risk of thrombosis and that is going to affect the graft function. So hepatic artery thrombosis is a very important diagnosis to be looking into whenever you assess a patient. So the incidence is about 2%. It can be detected early and up to 50% of the grafts can be salvaged with urgent re-exploration, thrombectomy or revision of the anastomosis. But unfortunately, about 50% of patients with the hepatic artery thrombosis eventually need a retransplantation. So we have covered about the artery. Then we need to also cover about the vein. So there can be also thrombosis of the portal vein or hepatic vein. It's less common than hepatic artery thrombosis. If it is diagnosed early, operative thrombectomy, revision of the anastomosis, especially if it is a portal vein thrombosis or endovascular stenting, may be helpful. That is especially if it is suprahepatic IVC stenosis. But in late cases, late cases who come with a portal vein thrombosis, usually collaterals start to develop. So those kind of subsets, retransplantation is not necessary. You need to look into management of portal hypertension. So hemorrhage, vascular, next is biliary. So like I said, one is you can have leak or you can have strictures. So either are problematic. So biliary leak typically occurs during the early post-transplant phase, and leak itself, bile itself is like a culture medium. So the problem is that itself increases the risk of infections. So clinically, there can be fever, abdominal pain, leukocytosis with elevated bilirubin. So diagnosis, either CT or ultrasound may be able to detect the leak, but cholangiography is needed for demonstrating an active leak. So if at all a cholangiography is not available, then you need to go with a HIDA scan. That is a hepatoimmunoacetic acid scintigraphy. So for vascular complications, you can go ahead with the Doppler. That itself will be able to identify the problem for you. For biliary complications, CT and ultrasound may be able to identify the initial problem, but for definitive diagnosis, you need a cholangiography or a HIDA scintigraphy. So management is drainage and endoscopic stent placement. If at all it is not successful, then you need to go with operative repair. But any post-transplant patient, if the patient is going to go for a resurgery, the morbidity, mortality goes up by 2 to like almost 50%. One side there is a biliary leak, another side there can be biliary strictures. So it's usually anastomotic and it can be because of ischemia also. So mostly patient presents with cholestasis. So usually you will see that even though the clinical transaminases are coming down, the bilirubin keeps shooting up. So along with that, if at all the patient starts to develop features of sepsis, there can be an evident cholangitis also that can be associated. So usually the diagnosis is through ultrasound, MRCP plus or minus cholangiography. So management is a balloon dilatation plus a stent placement. If at all endoscopic management fails, you need to go with surgical revision. So in both of these biliary complications, the first line management is to go with endoscopic management. If endoscopic fails, then you go with surgical. So we looked into hemorrhage, vascular, now biliary. So the fourth is related to wound complications. So there can be infections, hematoma, or seroma. So usually they present with increasing pain, erythema, or fluctuance will be there around that site. So the management is you need to open the wound, perform serial dressings, and if there is significant cellulitis or symptomatic symptoms, then cultures need to be sent. Broad spectrum antibiotics are needed, and then antibiotic de-escalation stewardship needs to be done once the cultures are available. Then another bone complication are incisional hernias. So it is often associated with preoperative malnutrition, attenuated fascia, or immunosuppression, and they often require surgical repair, especially if it is symptomatic, meaning there can possibility of obstructive symptoms start to occur. And primary non-dysfunction. So one thing I want to make clear is primary non-function and rejection are not the same. Two are totally different terms. So a transplanted graft is unable to perform vital synthetic and metabolic functions. The recipient must be retransplanted or the risk of death is likely to occur within 1 week itself. So the important thing regarding primary non-functioning, it is a diagnosis of exclusion. So you need to exclude hepatic artery thrombosis, accelerated rejection, and sepsis first. That is, the other complications have to be ruled out before you come to a final conclusion that it is a primary non-function. So regarding the treatment part of it, the definitive is definitely you need to put a retransplant. But temporizing measures, they say you can go with prostaglandins, plasmapheresis, or go with Mars. So with regard to the surgical related issues, we saw 5 issues. One was hemorrhage, vascular, that is arterial thrombosis, hepatic artery thrombosis, hepatic venous thrombosis, or portal vein thrombosis. Then we saw biliary complications, either in the form of a leak or a stricture. Then wound complications, wound site infections, hematomas or xenomas, or they can be incisional hernias. And last is primary non-function. So we covered the basic and surgical issues. Now we are covering the non-surgical issues. So we can go system-wise. So first is neurological. It often relates to the degree of preoperative encephalopathy, history of substance use, uremia, calcineurin inhibitor side effects, metabolic derangements like electrolyte imbalances, or a poorly functioning graft. So any patient who persists to have a poor sensorium, you need to look into all these factors to make all these factors, meaning you have to consider all these as possible differentials to make your final diagnosis. So clinical findings are usually persistent decreased level of consciousness, or if at all they are very much encephalopathic, or they have any structural brain lesions that develop de novo, that is new onset, then they can have seizures or focal neurological deficits also. So as for any neuro case, your if at all the patient has having encephalopathy, you need to work up in a very systematic way. So you need to first go with blood investigations, look at the electrolytes, look at the ammonia, then you look for the trough. If at all is on TAC level, TAC, then you need to look at the TAC levels, and you then need to look at the neuroimaging. So either CT or MRI, whichever is feasible. If it's hemodynamically stable, can be transported, then you can go with the MRI itself, which will be better. Or you need to go with the CT. If you need to do it fast and you need to rule out any bleed or an infarct. And along with that, you need to do an EEG. So blood, neuroimaging, and EEG. So these three things need to be done, and EEG to rule out a status. That's an NCSC. If at all there is no evidence, status. So in the subset of patients who develop encephalopathy, you need to avoid benzodiazepines. And if they are agitated or they develop any kind of psychosis, then you have to consider antipsychotic medications like haloperidol and risperidone. An important thing that you need to keep in mind is these patients are on multiple drugs. So drug interactions is the very big concern when you use antipsychotics also. So clinical pharmacists help always needs to be taken during this time, because any drug interaction is there, any dose modification is there that needs to be done, has to be done very carefully. Next is cardiovascular. Usually post-transplant phase, it's a hyperdynamic phase, characterized by high cardiac output and slow systemic vascular resistance. So why does it occur? It's mainly because of alterations in the nitric oxide metabolism, which generally improves over time after transplant. So usually in the first 24 to 48 hours, you will see that they will be on triple vasopressors, but over time they usually start to resolve. So in most patients, there will be advanced hemodynamic monitoring already connected. So it will be very easy to identify what problem we are dealing, whether it is hypovolemic, cardiogenic, distributive, or any kind of obstructive features. So those kind of findings, those kind of a shock can be identified easily. Then pulmonary. Now, dysfunction can be pre-existing or can be new onset. So it can manifest either as an atelectasis, can be because of incision site pain, because of inadequate analgesia. There can be a hepatohydrothorax, especially in patients with chronic liver disease. And there can be mucus plugs also, they can be present. So aim treating the underlying cause. Then pulmonary edema and pleural effusions. So they can be exacerbated by massive transfusions or severe hypoalbuminemia. So the main management is careful fluid administration with judicious use of diuretics. Because diuretics in post-transplant patients is a double-edged sword. So you may think that it's giving you benefit, but it can like cause a lot of harm in ways we cannot imagine. So it's very, very careful. It needs to be very carefully titrated. Pocket in is drainage of moderate to large effusions and assess for malpositions if pre-existing tubes are already there. Then if hepatopulmonary syndrome is there, usually post-transplant it starts to resolve. So if at all the features are there, you don't have to worry about it. Usually the trend starts to come down. But on the other side, if portopulmonary hypertension is there, then you need to be concerned because portopulmonary hypertension does not reverse post-liver transplant. So if at all those features are there, then you need to manage with vasodilators, inhale nitric oxide, and go ahead with the restrictive fluid management. So the main purpose of doing all this is to avoid RV failure. So if RV failure is there, it is going to cause a bigger bump because already you have a new liver recipient, and if at all it goes into a congestive hepatopathy, it's going to further cause new and new problems. So that needs to be looked into very seriously. Then ARDS post liver transplant is rare, but if it occurs, it is supposed to be lethal. So management, like we all know, is to go with protective ventilatory strategy, mainly to prevent barotrauma and nosocomial infections. Like I said, pneumonia is one of the most common causes of most common infections post liver transplant. So it can be either the typical or opportunistic, like PCP. So we covered neuro, CVS, pulmo, and coming to renal. Renal AK is common in liver recipients and is associated with increased perioperative mortality. So pre-transplant etiology most commonly can be because of HRS, toxin-mediated ATN, or medical comorbidities like diabetes. In the post-transplant phase, it can be because of hypovolemia, ATN, that can be because of ischemia, and drug toxicities like calcineurin inhibitors. And immunosuppression related problems like post-transplant diabetes and hyperlipidemia need to be addressed seriously. Opportunistic viral and fungal infections, usually these occur between 1 to 6 months. So the easiest way to remember is less than 1 month post-transplant, it is all nosocomial, VAP, CRBSA, CAR-T, those kind of things are the things you need to look into. Whatever we see in our ICUs commonly. Between 1 to 6 months, it is more of opportunistic infections plus reactivation of your latent infections, which are probably previously there, like hepatitis B, hepatitis C, cytomegaloviruses, or any other viruses that were previously there, which are dormant, may get activated. Usually, after 6 months, it is most commonly because of community-acquired infections. And post-transplant related lymphoproliferative disorders can occur, and there is also an increased risk of squamous and basal cell carcinomas. As Madam had told, usually malignancy is one of the causes of mortality in most recipient patients. And there can be recurrence of the primary liver disease itself. So they may require treatment and it may significantly impact graft survival. So recurrence meaning there can be reactivation of your hepatitis B. So usually in these cases, they go ahead with the prophylaxis with hepatitis B immunoglobulin, plus they give a nucleoside analog like lamivudine or entecavir. For hepatitis C, the problem is even if you do a transplant, at 5 years post-transplant, there is a high risk of recurrence, despite antiviral therapy. And for autoimmune liver diseases, like I said, even after tapering your steroids, you need to continue it lifelong because you need to keep the autoimmune status under control. So we looked at the neuro, cardiovascular, pulmonary, renal, immunosuppression related, and the recurrence of liver disease, primary liver diseases. And the last one is primary graft rejection. So the one thing they say is before you go into a diagnosis of primary graft rejection, first thing is you need to rule out the surgical causes. That is, you rule out hepatic artery thrombosis, portal vein thrombosis, biliary leaks or strictures. Then after that, you then look into these factors. So allograft rejection should always be confirmed histologically. Just lab reports are not going to be sufficient because you're going to have a wide differentials because in most of these patients, they're going to have hyperbilirubinemia, coagulopathy, transaminitis. So these things can occur with any kind of condition. So it's going to be very difficult to identify. So if at all you need to make a diagnosis of primary graft rejection, and histology diagnosis is essential. So like I said, rejection consists of 3 types: T cell, B cell, or antibody mediated and chronic. So empirical therapy current ESL guidelines, they say empirical therapy just with boluses or steroids should be strongly discouraged. So once you make the diagnosis, immunotherapy has to be initiated. For a T cell rejection, they say to go ahead with methylpred plus ATG, that is anti-thymocyte globulin. And if it is antibody mediated, that is B cell mediated, then you need to go with methylprednisolone plus or minus rituximab. So the main rationale for giving for antibody mediated is B cells will have CD20 markers present on them. So rituximab is basically a CD20 inhibitor. So it goes, that's a CD20 inhibitor map. So if you are administering that, that will help to destroy the B cells and decrease the rate of rejection. So this I had taken from this ESICM article that had come 10 tips for intensive care management. So this is just, I've just kept this slide as a like a revision tool. So before your exams, if you just have a small snapshot of this during the exams, at least for those 5 pages, you can fill something based on these pointers. So this article I've uploaded in your articles that folder, so you can just have a look into that. So this is about the first presentation. So next I'll go about quality indicators. So this talk took some time because I wanted to be very elaborate, because this usually comes as a long case also. So they will ask you in depth about all these factors. So if you have a gist of this, from this you can go ahead and build upon, and it will benefit you in many ways. So the next talk is on quality indicators. So that is relatively a short topic. So I think that I'll try to finish it as early as possible. So is the slide visible?
Yes, sir.
Okay. So coming to the quality indicators in ICU, just 4 areas I'm going to cover under, because one is introduction, objectives, parameters, and discussion. So coming to the introduction, the main reference I've taken for this is based on the ISCCM guidelines, which have come in 2011. So it has not changed so far, and it holds valid till now also. The other quality indicator guideline that can be looked into is the NHS guidelines. So since we are in India, we go with this, but there are some corporate centers which does go ahead with NHS. Now, why quality indicators in ICU topic per se is important is both from theory and practicals. First, I'll tell about the practical part of it. In practicals, one station is separately dedicated for quality indicators. Problem is most of us don't read this because in the last minute we only concentrate on the cases. But this is one of the highest scoring areas because there are only around 15 indicators you need to know, and if you are, they will ask you about 2 to 3. For me, they had asked VAP rates, then they asked CRBS rates, and they asked about readmission rates. So if you know all three, you already answered around 50, you get 15 marks easily. So that boosts your practical score. So this is one area many people don't really read, but I really say that it's a very high scoring area. And from a theory perspective, they usually combine 2 to 3 indicators together and they ask it like a 5-mark question. So from that perspective is also important. So quality indicator is a measure of structure, process, or outcome that can be used by local teams to improve care, and it helps to understand a system, compare it, and improve it. So the main objectives is to select very common parameters, mainly focusing on outcomes, that is morbidity and mortality, process, infection, human resources, and safety. So whatever I discussed in the previous slide, I've just made it in a more elaborate version. So for mortality, you can assess it by the standardized mortality rate. For morbidity, you can assess it by the iatrogenic pneumothorax or the decubitus ulcers that are occurring in the ICU. For process measures, you can go in with length of stay or ICU readmission rates. For error and patient safety, you can assess the patient fall rate, the medication error, needle stick injury rate, or the reintubation rate. For infection control, you can go with the VAP rate, the CRBS rate, CORTI rate, and the resistance rate. Surgical site infection rate can also be included, but that is more often operation theater predominant parameter that is looked into. So I have not included it under this. And last, under human resources, you have overall employee satisfaction rate and customer satisfaction rate. That is the patients. So totally I'll be covering 15 parameters. but I'll make sure that you all have a good clarity of this because this is very, very important. So first coming to the standardized mortality rate or the risk-adjusted mortality rate. So the main rationale is raw mortality is not a good quality indicator because it does not consider the difference in cases or the severity of illness. Because you may have an ICU where you have random set of patients, like in a multidisciplinary ICU, you may have a lot of patients who are coming and they may like die within 24 to 48 hours. But that may not reflect properly when you compare it with the other hospital ICUs because there is no proper standardization because they may be receiving a different subset of patients. They may be receiving milder, sick, like less sick patients. So they may be having better outcomes. So that may actually cause a bias. So when you use an SMR that is calculated from appropriately calibrated severity of illness scores, it helps to comparably audit the severity of illness predictive models. Simple to say, when you use an SMR, you are using a denominator as a this one, a risk-adjusted validated score. So when you do that, the results that are going to come out are going to be more validated, and you can use it for auditing among various ICUs. So when you're mentioning about any quality indicator, you discuss it under these four headings. One is the rationale, the population, formula, and interpretation. So for if at all it is a 5-mark question, if you answer each one half, you get at least 2 marks. So 2 plus 2, you get 4, 4 out of 5. So that will get you a good amount of marks for your 5-mark question. So the population, when you in whom you do the standardized mortality rate is for all patients admitted to the ICU. So the formula is pretty straightforward. The observed rate, that is the actual death rate in ICU, divided by the risk-adjusted expected rate. So I'll explain it very simple. See, you have an ICU where you had 100 admissions, and among that, 10 patients had died. So you take that amount of patients who have died as a percentage and divided by the risk-adjusted expected rate. That is the Apache 2 score. So in this Apache 2 score, for every patient who comes, you do a calculation, you get a certain number. The best number I can say is 25. For an Apache score of 25, you will have a predicted mortality rate of 52.5%, which will be quite accurate. So you need to divide this observed death rate divided by this rate according to risk-adjusted expected rate based on the
Srihari, you're not audible, Srihari. Hello, Srihari.
So sorry. So just going through standardized mortality rate again, just to emphasize again, raw mortality is not a good indicator because there is no uniformity. That is the best way to say it. So when you use an SMR, it is more validated, it is more uniform, and you can use it for auditing various ICUs. So the population is for all patients admitted to the ICU. The formula is the observed rate, that is the actual death rate in the ICU. That is the number of patients who died divided by the total number of patients, and the risk-adjusted expected rate that is taken as a mean. That is the number of patients who have been admitted to the ICU. You calculate the Apache score and then you take the mean of it. So the interpretation, if it is equal to 100, that is almost 1, then the mortality rate is equal to the expected rate. Whereas if it is more than 100, then the mortality rate is more than the expected rate. And if it is less than 100, the mortality rate is less than the expected rate. So I think this part of it is pretty straightforward. The formula is one area where I wanted to emphasize. So I hope I'm clear on that. So if you have any queries regarding to SMR, please let me know. I'll explain it again. So the coming to the iatrogenic pneumothorax, the rationale is procedure-related pneumothorax is associated with increased morbidity and mortality. So all of us know about that. It is also associated with prolonged ICU stay and increased cost. So that is the main rationale for it. So the main population again is all ICU patients. So the formula for this is pretty straightforward. It is the number of cases of iatrogenic pneumothorax by the number of ICU cases in a month. And usually they take it per 1,000 patients, per 1,000 cases. So this per 1,000, per 100, per 10,000, there is no any standard value per se. Since we are following the ISCCM indicators, we go with the same patterns just to make it more uniform. So the benchmark they say is it should be around 0.83 per 1,000 cases. If it is more than that, then it is a serious problem in our ICUs, which we need to look into. So next is decubitus ulcers. So decubitus ulcers and pressure sores are synonymous. So most of us know about it. So prolonged uninterrupted pressure over bony prominences causes necrosis and ulcerations. So hip and buttocks alone contribute 67% of pressure sores. So the problem with these pressure sores are it is associated with the increased cost of care and it also increases the risk of infections. So the patient population again is it's confined to ICU patients, and the formula is the number of cases with pressure ulcers that have developed new onset. The important thing is there are many patients, many debilitated patients who may be admitted to the ICU, like already stroke with long-term and bedridden status who may already have ulcers. So those patients do not come under this criteria. So exclusively those who have developed new pressure sores in the ICU are the ones who are looked into, and that you need to divide it by the ICU cases that are present in a month. Usually, when they take a census, usually when you do a monthly meeting, usually they'll have a census of a number of cases that they have taken, like the number of cases that have been admitted in the ICU. So that is your denominator. So the benchmark is 22.7 for 1,000 cases, or 3 to 11% of the ICU cases. So this benchmark and numbers that I'm mentioning is just for your knowledge. From an exam perspective, if you're able to remember it, well and good, but at least the formula should be clearly kept in mind. So the length of ICU stay. So this is one area which I want all your concentration to be with. So the main rationale is the ICU beds are limited in any hospital, that all of us know. Because in a 500 bedded hospital, the maximum ICUs may be around 20 to 25. So if the patients are getting sick in the ward, there is always a issue with ICU admissions because of the lack of vacancies. So rationale is used for needing patient for the needing patient is very necessary. So the length of ICU stay is used to assess the quality of care and the resource utilization. So the total hours and days the patients are managed in ICU with midnight bed occupancy is taken as the variable under consideration. That is the most accurate. So I'll just express this once again. See, usually when you're taking the census, right, you need to take it from the 12 a.m. So the time at 12 a.m., how many patients are there in the ICU is taken as the number of patients in the ICU. I hope all of you understand. So the number of patients in ICU is considered as the number of beds that are occupied. So if you are having a 14-bedded ICU, and if the number of patients who are there at 12 a.m. are 10, that means the number of patients, number of beds are 10 beds are there. So I think this part is clear. So for the formula, they say that the total occupied bed days. So that is nothing but the number of beds that are there at that point of time is calculated for that whole month. So if there are 10 patients on a particular day, on another day there are 14 patients, on another day there are 12 patients. Usually the mean is calculated and that is multiplied by 30 or 31 days. And the denominator is given by the number of ICU deaths or discharges in a given time frame. That is we usually take it in a month because during every usually the mortality meet or monthly meet audit comes every month. So usually we take it in a month and we calculate this. Though in most of our ICU setups, we take it the total occupied bed days as a mean. The distribution of data is usually skewed. That is, it is very ununiform. So they usually say the median will be a better marker to assess the total occupied bed days. So I'm just emphasizing on the numerator again. For calculation of the total bed days is one parameter is the number of beds that have been occupied into the total number of days in that month, that is 30 or 31. So for the first parameter, the number of bed days, that is the number of patients that are there in the ICU, that the number of beds that are occupied is taken as a mean or a median, and it is multiplied with the total number of days. That will give you the total occupied bed days. And the denominator is the total number of ICU discharges or deaths in a month. So for a general ICU, the usual normal length of stay is between 4 to 5, that is around 4.36 days, and for a vascular ICU, it is 2.36 days. So most of the practical vivas, this length of ICU stay is question is very commonly asked. So that's why I was emphasizing on this. I hope you have understood. If you have not, please let me know. I'll explain it later. So coming to ICU readmission rate, that is within 48 hours of ICU discharge, the rationale is a very high early readmission rate suggests a very poor ICU decision making during discharge. So the reasons that can be there is discharging occurring before the patient is ready for ward-based care. Sometimes we try to push out the patient before they're really stabilized. So in ward, you cannot expect the same level of care that is being given as in an ICU. So they may deteriorate and bounce back. So there can be incorrect use of ward care. That is like insufficient staff will be there. So you cannot expect the amount of care in an ICU in a ward. And deficient handover to staff taking over care and responsibilities of the patient. So that because of that, necessary medications or important maneuvers or interventions may be missed. So population is also the same. All patients admitted to the ICU. The formula is the number of admitted patients by the total number of patients admitted in the ICU. So this is also pretty straightforward. So the benchmark is around 5 to 6%. If it goes more than that, then it is very concerning and it needs to be looked in seriously. Then next is the patient fall rate. So it's an untoward event which results in patient coming to rest unintentionally on the ground or another lower surface. It can be an anticipated or an unanticipated accidental event which is associated with increased morbidity, prolonged stay, and it can cause customer dissatisfaction. That is customer dissatisfaction meaning the patient bystanders can be very unhappy, and that itself can cause new problems. So the population includes all patients, ward, ICU, but we usually take ICU patients. So the formula again is pretty straightforward. It is the number of falls that occur by the number of bed days. So the number of bed days, like I said, one parameter is the number of occupied beds as a mean or median, and the second parameter that you need to multiply it is the number of days in the month. So the interpretation is without injury is 2 to 2.6 per 1,000 patient days. And if an injury is occurred, the benchmark is 0.22 to 0.7 per 1,000 patient days. So medication error. So the rationale can be due to wrong medication, wrong prescription, wrong dose, or a communication gap. So many a times the verbal order is given over the phone. So the order that is given by the doctor is misinterpreted by the staff, and it can be lead to problems. So that's why in most of the NABH accredited hospitals, they have sound alike and look alike drugs. So the main purpose, one of them is related to this. So that's why they say high risk medications needs to be documented properly. So it can occur at a mean rate of 19% of hospitalized patients, and at least 2 out of this can cause significant patient harm. So the formula for this patient safety factor for this factor is number of errors by the number of bed days. Similarly, for patient fall, which is another safety related issue, was number of number of patients who had a fall by the number of bed days. So for measure of your patient safety, predominantly you need to go by the number of bed days in your denominator. So that is one way you can remember it. So needle stick injuries. So basic definition of a needle stick injury is a penetrating stab wound from a needle or other sharp objects that may or may not be associated with exposure to blood or other body fluids associated with transmission of bloodborne pathogens. Basically, it is a preventable injury, hence adequate training to healthcare professionals is a must. So the population here includes all healthcare workers. So the formula is the number of total stick injuries reported in a month by the total number of staffs in the ICU. So that is the basic formula for this. And here you take it per 10,000. for SMR it was 100. The rest of the other 6 parameters we spoke, it was 1000. For this, it will be 10,000. So the interpretation is 0.94 per 10,000 mini punctures. So that is the benchmark. So reintubation rates. This is pretty straightforward. Reintubation within 48 hours of extubation. Why are we concerned is accidental extubations can lead to prolonged stay, longer ventilation, higher VAP rates or higher VAP rates. So formula is number of patients reintubated by the number of patients extubated into 100. So SMR and reintubation rates have the 100 as the marker. So the benchmark is 12%. So if it is more than that, it is concerning and it needs to be looked into. Morbidity and increased costs. So the
Srihari, your voice is cutting, Srihari. Hello.
number of patients it sounds very pretty straightforward, but how do you take into account for the number of beds? You do a midnight census. In that, you see that the total patient census is 10. During that time itself, they will look into the number of patients who have been intubated. So that number of patients, probably there may be 2 or 3 patients who may be intubated out of the 10 patients who are admitted. So those 2 patients will come under the ventilator day, 2 ventilated days. Similarly, that has to be calculated to 30 days. In that you take a mean. So over the 30 days, the amount of patients who have been on ventilator, that mean is taken and that is your number of ventilator days. I hope I'm clear. So the
Srihari, I
benchmark,
think your
yes,
sorry, your voice has cut multiple times in between. Can you just repeat this VAP rate?
sure, no,
They
one
are
second.
requesting you. Yeah, thank you.
Sure. Okay, now is my voice okay now, ma'am?
Now it's okay.
Okay, I'll just talk about VAP, the ventilator days part alone again. See, for ventilator days, like I said, for ICU bed days, you see the number of patients that are admitted in the ICU in your census at 12 a.m. That is your midnight census. So out of 14 beds, if the bed occupancy rate is 10, then the ICU bed day for that one day is 10. Similarly, when they do the midnight census, they will also be assessing the number of patients who have been intubated on ventilator. So out of 10 patients, one day there may be 2 patients, one day there may be 4 patients, one day there may be 5 patients. So what they do is they usually take each day they calculate the number of patients who are intubated. So for a period of 30 days, that number is taken and then the mean is calculated. So that value comes out to be your number of ventilator days. So the number of patients with VAP by the number of ventilator days will give you your VAP rate. So the benchmark, which is important for us in medical ICUs, the VAP rate benchmark should be 2.5 per 1000 ventilator days. Whereas for a trauma ICU, it should be 9.3 per 1000 ventilator days. Neuro ICU, it should be 7.1. And neurosurgical ICU, it is 6.5. Anything more than this is concerning. I hope this discussion, this definition discussion was clear. If anyone has a query, please let me know. If it was okay, could you just give me a thumbs up so that I'll go on to the next topic, next part of it. Okay. So coming to bloodstream infection rate, that is CLABC or CRBSA rates. Bloodstream infection rates due to a central line, but it can be due to other catheters also. So the rationale is the use of CVCs is indispensable in the treatment of critically ill patients. So infections is one of the most common complications of intravascular catheters and it is associated with increased morbidity and increased ICU length of stay by almost 5 to 8 days. It's almost similar for VAP. So the formula is the number of patients diagnosed with central line associated bloodstream infections by the number of central line days in a month. So like I said, again, when they do the midnight census, they assess the number of patients who are there. in the ICU, and they assess the number of patients who are intubated. And along with this, they also take a note of the number of patients who have a central line and an arterial line also. So based on this, the number of patients who have a central line then can be calculated in that like per day. And for 30 days, the average, like the total can be taken and it can be averaged. So that will give you the number of central line days in a month. So the benchmark is similar for medical ICU, it is around 2 to 4. For VAP, it was 2.5. Trauma ICU, it is 4. Neuro ICU, it is 1.2. And coronary ICU, it is 2.1. So numbers, if it is possible, please remember, but at least medical ICU alone, try to remember it because it is the area where most of us work. With regard to CAR-T rates, the formula is, again, the number of patients diagnosed with CAR-T divided by the number of catheter days. Like I said, this is the same thing. During the midnight census, when they calculate the ICU bed status, they also calculate the intubation rates, the number of patients with central lines, and also they will assess the number of patients who have a Foley's catheter in situ. So based on that, if one day they have two patients with the catheter, on another day they have 5, then it is calculated for 30 days. The number is taken, then it is averaged. So that will be your number of catheter days. So the only very concerning thing over here is in Burns ICU, usually the benchmark for CAR-T rates is they say is high. It's around 7.7 compared to all the other ICUs. So VAP rates for a medical ICU it's 2.5. CRBSC rate for a medical ICU is 2 to 4. And CAR-T rates in a medical ICU is 4. So it all comes between 2 to 4. So at least in the exam, you can put it as a reference range so that in some way you will compensate for something. The next is about the resistant index. So the main rationale for this is to assess the epidemiological trends of organisms in the ICU. So antimicrobial resistance is associated with increased morbidity, mortality, financial burden, and length of stay. So I had discussed about this during our discussion on antimicrobial stewardship. So the formula is very straightforward. That is the number of resistant isolates by the number of isolates tested. They say that the important thing to note is at least 30 isolates are needed for an accuracy and a precision. So the only thing is it varies from institution to institution. So this provides the foundation for selection of antibiotics for specific sets of infections. Like each antibiotic, like in each hospital, the antibiogram for an organism will vary. So that is considered based on your resistance index. The last two are predominantly HR related issues. One is overall employee satisfaction. So the main rationale they say is satisfaction level of staff working in ICU. Satisfied workforce gives better work output and the retention rate is high. So all this comes in relation to humanization in ICU. So the formula, there is no formula as such, but they usually go with the questionnaire method based on a scoring from 1 to 5, where 1 is the lowest and 5 is the highest. So the benchmark which is expected is to have a benchmark of at least 4. And the last one is a customer satisfaction rate. So customer satisfaction now, actually, it's a hard truth, but most of the hospitals are more like into a market kind of system. So things is like patients are like customers, and the attenders are also like a part of the customer system. So you need to keep them happy to get a good load of patients. So they say patient satisfaction is perceived parameter by the patient and it reflects the performance of the hospital as reflected by the patient. So better the performance of the hospital as reflected by the patient, more number of patients are going to come to the hospital and better is going to be the performance and care and performance and care. So this is also a formula based, questionnaire based kind of rate assessment where you, rather than going from 0 to 5, you go with 1 to 10, where 10 indicates the best possible service. So the benchmarks that they say are satisfaction to physician communication should be 80%, nurse communication should be 74%, cleanliness should be 70%, noise 50%, patient management 68%, and recommend the hospital to others should be at least 68%. So just a small tip, in the exam, if at all you get This is very unlikely to be asked. Just for completion, it was given. But your bad luck, if at all they ask, the benchmarks can be measured as a range between 50 to 80. So invariably, everything will come within that. So I think we have covered the 15 parameters. So the important areas which I really wanted to emphasize is on the ICU bed day, ventilator day definition, then catheter day definition, and central line day definition. So these 3 to 4 things are what they will be asking in the exam, because most of us for the practicals will mug up and go and we will like vomit out the formulas. But few of them will specifically ask what is this ventilator day. So at that time, if you try to beat around the bush, then your marking is going to come down. So this is what the main gist of it is. And no, just because I don't know whether I'll be able to convey this later on, but once you finish your theory, my personal suggestion is at least do one monthly meet auditing, because when you practice these quality indicators once, you will not forget it. So when you answer it in the exam, you can answer it with more confidence, so that will fetch you more marks. So thank you for your patient listening. Sorry for the break in the signal. I think in between the current had gone, so I had to use my phone hotspot, but the signal was bad, I suppose. So thank you very much.
Yeah. Thank you, Srihari. It was a very good class on this quality indicators.
Thank you, ma'am. Thank you, ma'am.
Yeah. So this completes all your topics for today. So tomorrow we will be dealing about some important topics in trauma and difficult ventilation in, difficult airway management in ICU. Okay. Thank you all. Bye.